pandi biraga tapang rasa manjatu kambang layu ibarat kumpai laru salah jurhanyu salah jurhanyu salah jurhanyu salah jurhanyu. Lalu sampai akan yuka bulik pangsa tuman lawasnya menahadang pian meninggalkan kampung halaman kapal purunan yuka bulik pangdamini ulun tak sakit hati pianang ulun tangisi kadang sakira diri ulun barista yang datang ulun sambut lawan mayang ulun hamburi baras memburu pipit berdua bahu sutan. Hari bangunlah senja, kedap samun di rumah, berdua takut tanan. Kada seapa, lalu datang niaksa, pemakan manusia, awaknya panjang besar, sapuhun kariwaya, mutungnya Jawa benar, gaya kawah belakang, rambut banyak bakutu, halali penuan kalah. Mula hendak memakan, apa akal intingan, berdua bapantunan. Ukaka, ukiki, bani kita dimakan bibit. Ukaka, aneh-aneh bayi dikindik ku adik, ulat bulu nang mamutiki. Niaksa, niaksa, nang bungas langgar lagi pemberian, kami pangrela dimakan rangfian, mun diberi habu halaban. Daihon mamusuti, dibawa barabahan, sambil bakak kutuan, niaksakan nyamanan, lalu pangtaguringan, disimbur di matanya, awan habu halaban, niaksa kalimpanan, bakuriak kapadihan, intingan mandayuhan, hancap kasambunyian.
For decades, the pen light has been used to evaluate neurological function. It helped a lot of people, but even 100 pen lights, in the end, are still just lights. It's time for something more precise and objective. This is Neurolight, a pupillometer made by medical professionals, not an office supply store. It's a new era in pupillometry. Neurolight, it's simple to use and very precise. A pre-calibrated flash of light stimulates the pupil. Unlike the pen light, which enables subjective measurements, Neurolight captures precise pupil size and reactivity within 1/10 of a millimeter. And it takes just 4 seconds. You can measure multiple times, and the results are reproducible every time. Trend the data for prognosis. Just adjust the eye cup. You can measure both eyes to monitor anisocoria. Neurolight is very light in weight. The eye cups are reusable and block out ambient light. Neurolight comes with a barcode scanner and color touchscreen. And if you need to transfer data, Neurolight can do it wirelessly. It even has a wireless charger. Neurolight for neurological monitoring. It's that easy.
Pagar bintang, kekambanang habang kau bawa berjalan, aduhai kasihan. Kekambanang habang kau bawa berjalan, aduhai kasihan. Giwang dua, giwang berlian, giwang dua amas pangiri, urang jua nang menangisakan, kada tak hapus sakit nang garing. Giwang dua pakaian putri, adat sunting dalam istana, urang jua nang disakiti, kada tak hapus sakit nang garing, kada tak hapus sakit nang garing. Dirantau urang, dirantau urang, dirantau urang. Giwang-giwang dua, giwang-giwang berlian, giwang-giwang dua amas-amas pangiring, urang-urang jua nang menangisakan, kada tak hapus sakit nang garing. Giwang dua pakaian putri, kayakan di malam maba, kembang goyang di ujung galuh, pengantinnya sudah patimu. Waktu raja duduk pasang goyang di ujung galuh, emas murni pakaian putih, adat kawin dalam istana. Hurayakan mayang nan sakti, umpatakan balarut banyu, adat raja bamandi mandi. Hurayakan mayang nan sakti, umpatakan balarut banyu, adat raja bamandi mandi. Hurayakan mayang nan sakti, umpatakan balarut banyu, adat raja bamandi mandi. Hurayakan mayang nan sakti, umpatakan balarut banyu, adat raja bamandi
Sabujurangnya hendak ku sampaikan, hati ini karindangan lawan pian. Amun kaya apa cara menyampaikan, aduh supan memberi supan karindangan. Baduduk salah, badiri pun salah, kaya ini pang urang karindangan, ibarat kaya cacing kapanasan. Karindangan, 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 karindangan supang bapanan, sabang guring siang tabangun, sabang guring malam amin pipian. Tuhuk sudah mencari kesempatan, ada paham kapian lawan isyarat, amun pian dasar bahati batu. Aduh mama, aduh abah, karindangan. Baduduk salah, badiri pun salah, kaya inikah orang karindangan, ibarat kaya cacing kapanasan. Karindangan, 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 supan bapak sabang
Your Excellency, ladies and gentlemen, we cordially invite you to be ready.
Because in a few minutes, the opening ceremony will proceed in no time.
Thank you.
Bakiti di batang, titi batang di batang bulu, kuning manggading di batang bulu, kuning manggading. Malam tadi pemimpin. Yoga Banjarmasin, Nandingarani kota Saribu Sungai. Yoga Banjarmasin, kota nang tapandang wanang paling bungas. Yoga Banjarmasin, nang dingarani kota Saribu Sungai. Yoga Banjarmasin, kota nang tapandang wanang paling bungas. Yoga Banjarmasin, nang dingarani kota Saribu Sungai. Yoga Banjarmasin, kota nang tapandang wanang paling bungas.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Thank you for your presence and participation.
Her Excellency, the head of our today's event, Dr. Kenanga Marwan Sikumbang, Neuro Anesthesiologist Consultant.
Respectable Dr. Sudadi, Neuro Anesthesiologist Consultant, Regional Anesthesiologist Consultant, as President of SNACC from Indonesia.
Dr. Chang Chin Tet, as President of SNACC from Singapore.
Professor Dr. Tatang Bisri, Neuro Anesthesiologist Consultant, Obstetric Anesthesiologist Consultant as our steering committee.
Honorable, all the speakers from Singapore,
Philippines,
India,
Indonesia,
Japan,
Malaysia,
South Korea,
and Thailand.
and respectable all the participants.
Also, a very big thank you to our sponsor who has supported us so this event can take place.
First of all, let's praise to our Almighty God, Subhanahu wa Ta'ala, the most gracious, the most merciful, the creator and sustainer of the universe.
So that we can attend this seminar without any troubles and obstacles. Please pray according to your respective religion and belief.
Pray please.
Thank you. As a Indonesian proud citizen, let's listen to Indonesian national anthem.
audience, my name is Ade Rahmayanti
My name is Vesta Antares. It is an awesome and precious chance for us
to be your master of ceremony in this morning on 22nd January 2022 in our big event.
Second Biennial Neuro ICU Symposium. Second Joint Symposium Neuro ICU Indonesia.
Singapore.
Improving patient outcome from basic to advanced technology in neurocritical care.
Excellency, ladies and gentlemen, step the following agenda. The first opening remarks, as well as the report committee for the virtual Neuro ICU Symposium, will be delivered by Dr. Kenanga Marwan Sikumbang, Neuroanesthesiologist Consultant. We welcome you, Dr. Kenanga. The time is yours.
Thank you, Dr. Vesta and Dr. Ade, as our master of ceremony in this event. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, Professor, Doctor, colleague, and all our participants who join us in this morning. First, I would like to say thank you to Professor Dr. Tatang Bisri, Neuroanesthesiologist Consultant, Steering Committee, and I would like to thank you to Dr. Sudadi, Specialist Anesthesiology, Neuroanesthesiology Consultant, as President of INASNAS. I am very grateful, and it is an honor for me to become the chairperson of this event. I would like to report that our series of events has started from 8 January until 30 January 2022. First, we conduct total nutrition therapy course in 8 until 9 January, and then continue by continuous professional development for anesthesiologists and ICC course. And today we are in our virtual Neuro ICU Symposium event, and our last event will be continuous professional development for neuroanesthesiologists as our closing event. I would welcome Dr. Chong Chin Tet from Singapore. Thank you for your kindness to give opening speech in this morning. Good morning, Professor Kwek Tong Kiat. Good morning, Dr. Won Yuling from Tan Tock Seng Hospital in Singapore. I would welcome our beloved teacher, Professor Siti Chasnak Saleh, neuroanesthesiologist consultant, and very grateful that in here among us, welcome Professor Masahiko Kawaguchi from Japan, Professor Hari Hardas from India, the beautiful one, Dr. Geraldine from Philippines, Dr. Piman Suprung from Thailand, Dr. Leong Kok Weng from Malaysia, and Professor Haiku Kim from South Korea. Thank you so much for all speakers from across country and speakers from Indonesia for your support and kindness willingly joining our event. And thank you for our sponsorship. I hope that we can share knowledge and experience in this event. And please enjoy this today's symposium. Thank you. Wassalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Vesta, Dr. Ade.
Kenanga.
For the second opening speech will be delivered by Dr. Chong Chin Tet as President of SNACC from Singapore. We respectfully welcome. Please, Dr. Chong Chin Tet, the time is yours.
Okay, thank you, Chairperson Dr. Kananga, Dr. Sudadi, and Professor Tatang Bistri. On behalf of the speakers from Singapore, I would like to thank the organizing committee for organizing the second Joint Neuro ICU Indonesia Symposium. Because of the pandemic, I think many of us have not been traveling. We also have not been able to travel to meet our friends and colleagues in Indonesia for, I think, almost 2.5 years. So I just want to thank the organizing committee for organizing the symposium as an opportunity for us to continue to share knowledge and expertise. I would like to thank today's plenary speaker, Dr. Wong Yulin, Professor Kwek Tong Kiat, and Dr. Tu Tian Ning, who are from the Neuroscience Institute of Singapore and Tan Tock Seng Hospital, and then also Dr. Chong Shang Yi and myself who will be giving the talk tomorrow. So in conclusion, just want to thank all the committee members from Indonesia, and also look forward to meeting up with Indonesian friends as well as all the ASNAC friends as soon as possible when the pandemic situation allows. Thank you. Thank you, Chairperson. Thank you. Handing over back to you, Chairperson. Thank you.
Thank you, Dr. Chong Ching Tet.
The third remarks in the opening series will be delivered by Dr. Sudadi, Neuroanesthesiologist Consultant, Regional Anesthesiologist Consultant, as President of SNACC from Indonesia. Please, Dr. Sudadi, the time is yours.
Okay, thank you, MC. Assalamualaikum warahmatullahi wabarakatuh. Good morning, dear all honorable speakers and participants of the second joint symposium Neuro ICU Indonesia and Singapore. Alhamdulillahirabbil alamin. Countless thanks to Allah Subhanahu wa Ta'ala who has allowed us to meet again in the second joint symposium Neuro ICU Indonesia and Singapore, which has postponed in 2021 due to the COVID-19 pandemic. The COVID-19 pandemic that shook our normal order of life in March 2020 made us adapt to the new normal. In this new normal era, face-to-face meetings are gradually being replaced by virtual meeting, and greeting must be delivered online. However, I hope that this does not reduce the essence of this meeting itself, which is actually an effort to establish a relationship between us. My special thanks to Dr. Kananga and the committee from the Department of Anesthesiology and Intensive Therapy, Faculty of Medicine, Lambung Mangkurat University, who have managed this event very well. This year, the second joint symposium, Neuro ICU Indonesia and Singapore, which is held entirely virtually, is expected to be a place for us to exchange the latest information, update insights, and stay in touch. We would like to thank all the speakers from all over Indonesia, also from Singapore, Malaysia, India, Japan, Philippines, and Thailand, who have spared this time to share knowledge in this event. Even though we are spared by distance and time, I hope this event can be the best of use the advancement of Neuro ICU in Indonesia. That's all for now. Thanks for your participation. And here with Bismillahirrahmanirrahim, we begin the second joint symposium Neuro ICU Indonesia and Singapore officially. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Dr. Sudadi.
Before entering our agenda,
We proudly present a glimpse of the history and culture of South Kalimantan.
Yuka bulik pangsa tuman lawasnya ulun mahadang pian meninggalkan kampung halaman kapapurunan. Yuka bulik pangdam ini ulun tak sakit hati pianang ulun tangisi kada sakira diri ulun barista yang datang ulun sambut lawan mayang ulun hamburi baras si baras kuning bersemangat di muhara lawan pian datang ulun sambut lawan mayang ulun hamburi baras si baras kuning bersemangat di muhara lawan. Selamat datang kami haturkan. Salam ya salam, selamat datang saatnya. Ayo, ayo ke Kalimantan Selatan, beraneka destinasi wisata. Ajak semua sahabat dan keluarga ke Kalimantan Selatan. Kamilau intan bumi cempaka, ragam kuliner yang menggoda, kasturi floranya, bekantan satwanya. Terjaga budaya pasar terapungnya. Semua hanya ada di sini. Ayo, ayo ke Kalimantan Selatan, beraneka destinasi wisata. Ajak semua sahabat dan keluarga ke Kalimantan Selatan. Ayo, ayo ke Kalimantan Selatan, beraneka destinasi wisata. Ajak semua sahabat dan keluarga ke Kalimantan
Thank you for the attention. We warmly welcome you to visit South Kalimantan. For all the panelists,
We kindly invited you to open the camera for snapshot together. Please, for all the panelists, opening the camera. We kindly invite Dr. Geraldine to open the camera. Yang belum. For Professor Hari Hardas from India, please kindly open the camera.
Prof. Masahiko Kawaguchi, please open the camera.
Thank you, barangkali ya. Thank you.
Proceed to our agenda. As for the series of virtual Symposium Neuro ICU event consisting of 2 days. The first day consists of 3 sessions, plenary lectures, neurological emergencies, and traumatic brain injury.
As for the second day, consists of 2 sessions, cerebrovascular, brain and spinal cord, and also flow session.
We will read some rules. First, send in your question and comment via the Q&A section.
For the second, chat and raise hand functional are disabled.
Third, our moderators will highlight your question to the appropriate speaker during panel discussion.
For the first session of plenary lectures, we have 2 speakers. Sorry for the mispronunciation of name. Dr. Wong Yulin from Singapore.
Professor Dr. Siti Chasnak Saleh, neuroanesthesiologist consultant, intensive care consultant from Indonesia. As for the moderator is Dr. Sudadi, neuroanesthesiologist consultant, regional anesthesiologist consultant.
Before we hand over the host of the session to the moderator, allow us to read a little CV about him.
He was graduated from Medical Faculty of Gajah Mada University. Then he continued his studies as anesthesiologist at Faculty Medicine of Gajah Mada University, and advanced his studies for neuroanesthesiologist consultant and doctoral degree at Pajajaran University.
Now, he is the Secretary of Department Anesthesiology and Intensive Care in Dr. Sarjito Hospital, Yogyakarta. We welcome you, speakers and moderator.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Thank you for Master of Ceremony, this nice introduction.
As for Dr. Sudadi, as for the moderator for this first plenary lectures, is there any trouble?
Oh, hello, your ear mic on?
Thank you, Dr. Sudadi.
Right. Okay. And begin right now.
Yes, Doc, we can begin right now.
Okay, thank you. Okay, in the first plenary session, we invite two speakers, Dr. Wang Yulin from Singapore and Professor Siti Hasnat Saleh from Indonesia. The first lecture with the topic Managing Neurologic Emergency During the Coronavirus Pandemic, presented by Dr. Wong Yulin. Can committee present the CV? The first, Dr. Wang Yulin, please. Okay, Dr. Wang Yulin from Tan Tock Seng Hospital is a consultant in Tan Tock Seng Hospital from 2015. Okay, please, Dr. Wang Yulin, it's time for yours. Is still mute? Okay.
Good morning. Thank you very much for the kind words. Also want to say congratulations to the organizing committee for being able to organize this during the pandemic era so that we can all meet virtually and learn from each other. And I would also like to then say that I'm going to share my screen now, and I hope everybody can see this. And the topic I have today is managing neurological emergencies during the coronavirus pandemic. I'm just going to use this next 25 minutes to talk about SARS-CoV virus and the pathophysiology associated with neurological manifestations. And then I would also like to speak a little bit more about COVID-19 and specifically for stroke, because for stroke, it is a time-sensitive disease that allows us to have a good outcome if we can get thrombolysis, thrombectomy in terms of treatment strategies, and even the need to go into the operating theatre urgently. And then we're going to talk a little bit about our Singapore experience and how we've had to change our workflow a little bit and how we resource allocate when we had the pandemic and having to look after neuro-COVID patients. And I will just go mainly into the strategies and management that we have done. And there are many speakers after me who would talk about the treatment for the rest of the neurological diseases like encephalitis and ischemic attacks. Okay, so the coronavirus up to date has actually caused more than 300 million infections and in excess of 5.5 million deaths. This global pandemic has been going on for more than 2 years, and the virus seems to really get the better of us, with it being able to mutate to get more infectious and more transmissible, with the Omicron that we see now that was first detected in South Africa, and before that, the Delta variant, which was detected first in India. It is part of a novel coronavirus, which is a single-strand mRNA virus of the beta coronal family. It was first discovered in Wuhan when it was identified as a cluster of pneumonia cases then. And the COVID-19 comes from the acronym coronavirus disease of the year it was identified. And in patients, while we think that the SARS-CoV-2 virus will cause mainly respiratory diseases, actually neurological presentations are not uncommon, and the incidence of stroke has been reported about 2 to 5% in the literature. Not only that, patients will also present with or continue to have neurological complications even in the chronic phase and in patients with long COVID syndromes. And therefore, it does have an impact on our healthcare system, both in the acute and potential chronic setting as well. The time course of the disease ranges from firstly the acute viral response phase and then goes to the host inflammatory response phase over a period of time. How this time course projects itself out and the severity of disease does actually depend from patient to patient. And even in this era where we have therapeutics and even vaccination programs that have been rolled out, the pandemic has really taken a toll on healthcare as well as morbidity and mortality. There have been many multifactorial pathogenesis for which the SARS-CoV-2 virus can cause CNS involvement, the central nervous system involvement, and it is said to be a multitude of all of these factors, either alone or in combination. And so the SARS-CoV virus can actually cause direct infection injury, both by a bloodstream spread or via a retrograde dissemination through the neural pathways. Anaerobic metabolism can also result in hypoxic injury to the brain, and due to endothelial injury and activation of the ACE in receptors, these can also lead to autonomic dysfunction and dysregulation of blood-brain barrier and blood flow in the brain. The surge response from immune-mediated injury with cytokine and hyperinflation would also result in disease process that we see in strokes, encephalitis, and even post-infectious toxic encephalopathy. And a lot of these patients are also in a hypercoagulable state due to micro and macrovascular thrombosis, and all of these do contribute in one way to another to the CNS involvement for patients who present with COVID. Due to the pulmonary disease, due to direct invasion of the nervous system, and due to post-infectious immune-mediated complications, the neurological diseases that are commonly seen, encephalitis, a stroke, as well as some of the peripheral nervous system like myalgia, muscle damage, as well as the Guillain-Barré syndrome and its variants. And so for cerebral vascular disease, we know that there is a baseline data that we know that it is quite prevalent. But in patients with COVID-19, the incidence of stroke is actually higher than the baseline population and is said to be between 1 to 5% in the literature that has been reported. There also have been quite a high preponderance for intracranial hemorrhage as well as cerebral venous sinus thrombosis. And the risk of stroke has been shown to vary with the severity of COVID-19. And although these mainly affects the large vessel occlusion and stroke in terms of territorial infarcts, we also see that there are also those that cause microvascular thrombosis. And the infection, we think, is due mainly to a hypercoagulable state, as well as the risk of cardioembolism, because these patients not only have respiratory disease, but also have cardiac arrhythmias as well as cardiac myopathy. This was a paper that was published looking at a cross-reference of patients with COVID-19 across China, and Mao was one of the first published with regards to the COVID-19 numbers in Wuhan. Romero from Spain, from UK, France, Italy, and even Turkey. There is a whole wide of patients with COVID-19 that has been published, and it is not unsurprising that many of these patients do have neurological manifestations, and stroke is also very high up in terms of a neurological presentation, in terms of an emergency we want to look at, and how we can try to ameliorate some of the devastating neurological disability and mortality if we have the correct information in front of us. These are just some CT and MRI images of the neurological findings in patients with COVID-19 and stroke. And you can see mainly it does have ACA, MCA territory and large vessel occlusion infarcts that can be seen here. So we want to see whether is COVID-19 during this pandemic era really related to stroke. And this was first published in Italy, and when the virus actually spread beyond China, actually Europe and actually northern Italy, Lombardy was one of the first few countries that was very badly hit in terms of their healthcare system and in terms of death toll. And in this, they showed that these patients, there was a stroke center, and they looked at the number of patients who were admitted consecutively to an emergency department with neurological symptoms. And of the patients, and there were about 530% of them were actually COVID positive. And when they broke down the patients in terms of disease process, patients who were COVID positive had an increased risk of getting a diagnosis of stroke and encephalitis, as well as an altered mental status with regards to delirium. Over time, the rate of hospitalization for patients with COVID and neurological symptoms was pretty constant at about 30% over a time course. Then we want to see whether there really is an increased incidence of stroke. And this is another paper that is published by the Italians. And they showed that if they looked at data of transient ischemic attack, hemorrhagic stroke, ischemic stroke, and epilepsy as the 4 major disease process that they looked at, and then they also averaged out a number of cases they saw pre-pandemic and post-pandemic. So if you look at the blue line, that was TIAs, and the first blue line shows TIAs in an average period for 10 years from 2010 to 2019. And the second one showed the period for TIA incidence in the year 2020 during the pandemic era. And actually for all except ischemic stroke, it seemed pretty stable. In fact, you could say that some of them actually decreased, and it may be due to the fact that patients who were not so severely ill, such as a TIA, did not present to hospital due to the lack of medical facilities, or they were told to stay home. However, for ischemic stroke, which is the green line, especially in March and April, and you see the line still going up, is that there seemed to be a double increase in terms of patients who present with ischemic stroke post-pandemic or during the pandemic era, as compared to patients who did not, as compared to patients during the pre-pandemic era between 2010 and 2019. This was another paper that was published by the American colleagues, and this looked at 2 academic hospitals in New York City. And Merkel showed, interestingly, that if we wanted to compare patients who had a stroke, and we know that a viral or bacterial infection does propensify somebody to get a risk of stroke, what is the baseline data if you just compare influenza versus the coronavirus disease? And interestingly, in this paper which they published, it showed that actually only a minority, which is 30% of patients, present to hospital with stroke symptoms. And that is the orange square that you see right at the left corner at 0. But many of them are presented to hospital with a non-neurological symptom, for example, shortness of breath, or actually having arrhythmia, but then develop an ischemic stroke during the course of their stay, and it could be up to 40 days after their admission to hospital. So we then have a preponderance. How do we manage our hospital resources to look after non-COVID stroke patients, COVID stroke patients, and COVID patients who then develop stroke whilst in the hospital? And so there is a whole dichotomy of patients that we need to look after and plan for. In patients who present with ischemic stroke during the pandemic, these patients usually have a higher NIHSS score, a higher stroke scale score. And these patients also then, if you compare the patients with influenza, had a higher risk factors such as hypertension, diabetes, and atrial fibrillation. These patients were also more likely to be admitted to the ICU, required mechanical ventilation, as well as prone positioning, as compared to the baseline influenza patients who then developed stroke. And therefore, when we looked at the analysis, COVID-19 was definitely more likely to result in acute ischemic strokes than those with influenza, and the odds ratio was up to 8. And even if you had adjusted for modeling, such as looking for patients with vascular risk factors as well as ICU admissions, actually the risks still remain higher for patients who had COVID-19 to develop stroke than for patients with influenza. So then if we have these patients who present to us in the hospital, is stroke in these patients any different? They seem to have a worse neurological admission score and is associated with higher mortality. This paper also looked at the 4 main neurological disease diagnosis, which was TIA, ischemic stroke, hemorrhagic stroke, and epilepsy. And this was published in the European Journal of Neurology. It's a different set of patients, and they compared data from 10 years before, from January 2010 to February 2020, and looked at the data with respect to patients pre and post-pandemic. And as you can see, the mortality for TIA has almost 10-fold, probably due to a delayed presentation to hospital. Patients with ischemic stroke, if they got it during the pandemic, had a 2-fold increase of in-hospital mortality up to 12.5%. And patients with hemorrhagic stroke had an in-hospital mortality of 47%. And this was almost double that of the baseline pre-pandemic. And therefore, the pressing challenges with neurological emergency, and especially with strokes, is that the timeline is going to be very, very short, right? So we know that the timeline, and it is time sensitive regards to thrombolysis and thrombectomy. But we want to know whether we can adequately treat these patients and not result in them having a mortality or having long-term neurological dysfunction. AHA guidelines actually recommended that patients with stroke in a COVID pandemic era would require some form of stratification as well as some form of triage. And therefore, if you get non-COVID, it's quite simple. You get your image, you get your treatment, and you go to an ICU or a high-D setting. In a COVID era, there are other things to think about. So in terms of infection control and the need for isolation, whether we need to then intubate these patients in a negative pressure room before we bring them down for an endovascular therapy, whether they are then going to be stable for transport, how do we decontaminate all our equipment after that, and where do we actually neuro monitor them in a safe place. And we've used some of these strategies in terms of how we have managed our Singapore experience, which we'll talk about later. And initially, some of the data showed that there was almost a 50% reduction in thrombectomies being performed due to healthcare resources being stretched and the inability to get patients in to the healthcare system quickly enough within the time frame of 4.5 hours for thrombolysis and 6 hours from thrombectomy. But interestingly, this paper actually showed that if you look at the key performance indices, which was the time from stroke onset to ED admission, from admission to imaging, and from imaging to therapy, that there was not much difference between a pre and a post-pandemic era. And in terms of how we have to manage our workflows, I think it actually starts from a pre-hospitalization phase, where we actually may need to reroute patients based on whether they are COVID-19 or not, whether they meet the screening criteria for both a large vessel stroke as well as the facilities to be able to house COVID patients with stroke symptoms, and then to look at how we communicate that information. And therefore, it is going to be a balance between flexibility and individualization of these protocols for different institutes and government and countries versus having a workflow that is quite standardized and simple for people to follow. And therefore, the reality really on the ground is that these are common complications that we have to think about when a COVID patient presents with a stroke. These patients may present with stroke, and it may be the first manifestation of the infection, but also to keep in mind that these may follow stroke after a previous COVID infection and may present with symptoms whilst in hospital and not as their presenting complaint. The higher your COVID-19 severity, the higher the risk of a stroke, and likely probably due to its pro-thrombotic effects from critical illness and from the SARS-CoV-2 virus itself. And we know and therefore have to keep in mind COVID-19 stroke patients are at higher risk for mortality and have a poor prognosis. And so what about our Singapore data that we have? Across the world, and I'm sure it is the same for all countries, stroke or neurological complications are a major cause of death and disability. And we have an incidence about 1 in 8 per 1,000 population, and the prevalence increases with age and with comorbids. It is one of our top causes of hospitalizations, and Tan Tock Seng Hospital, which you see in my background, is one of the 3 tertiary centers that are designed for thrombolysis and thrombectomy 24/7. And we want to make sure that our patients are not going to be disadvantaged due to the distraction effects of COVID-19, where resources and healthcare personnel may be reduced. So our Neuroscience Institute is one, like I said, a tertiary hyperacute center. We look at the most number of hyperacute stroke cases a year, ranges from between 1,500 to 2,000 cases a year. And we are in a unique position because we have direct access to the National Center for Infectious Disease, which is our NCID. It is about 2 meters across from us, and we'll do it by link bridges both at levels above and below. And it is our designated National Center for Suspected and Confirmed COVID-19 patients. And therefore, we came together to found a multidisciplinary work group to harmonize hyperacute stroke protocols to make sure it is safe, that we still keep our key performance index of a door-to-needle time of less than 60 minutes, and to actually minimize risk of exposure and cross-contamination of our non-COVID-19 patients. This is a picture of our NCID, which is across the road from the main Tan Tock Seng building, which is this. Okay, so how do we do and modify our hyperacute stroke care? We said, from the pre-hospitalization phase, and we had dedicated ambulances to bring high-risk patients who are under a quarantine order or a stay-home notice to go to NCID, where they were screened and treated by staff and neurologists who were in full personal protective equipment. The emergency department had a dedicated screening center for these patients. And in terms of management, these patients were then sent to a dedicated imaging facility, which was only for COVID-19 patients. And the imaging of choice as a protocol that we used was a non-contrast CT, as well as a 4-vessel angiogram to determine who was available, who was eligible for thrombolysis as well as thrombectomies. There was also a differentiation and segregation for ICU and OT, whether these patients were going to be non-COVID or COVID patients with neurological symptoms. Obviously, during the COVID pandemic, we had issues as well because there was a limit to a number of patients who could receive visitors, and a lot of the communication was through tele communication. There was also a need to minimize patient movement, and therefore it was in terms of thinking when a patient could be de-isolated or when an optimal time for a scan would be. And therefore we had to have defined transport routes. A lot of our access for education was put online so that people could get access to them easily. And we also did familiarization drills with simulated patients to make sure everybody knew how to go about getting the help they needed. And this was the paper we published in terms of how we could adapt our hyperacute stroke protocols to also encompass patients with COVID-19 in Singapore. And the workflow was quite simple. If you had stroke symptoms, you either had no infections concern and you went to the main block and went down the main block route, or if you had COVID-19 or had a risk of having COVID-19 and had stroke symptoms, then you had to go to NCID, have a dedicated scan there, and then be nursed in a multidisciplinary outbreak ICU. This is a setting of our busy emergency department, and this is emergency department staff being in full PPE, awaiting a patient that was to arrive. One of our colleagues made this nice pictorial diagram to show where everything was if you had to go to NCID. And so these are patients. If you thought that you needed a scan, then you go to level 2 via NCID radiology. If the patient needed to go to the NCID operating theatre for emergency intervention or needed to be housed in the ICU, then you would go to level 3, and there is a link bridge to main Tan Tock Seng building through that. If you needed to go to the screening center, then you would go to level B1. So it is a bit confusing if you did know where everything was and you were on call at 3 a.m. in the morning. But this was a pictorial diagram which we thought was helpful for staff to be able to be moving between the two campuses. The neurological emergencies that we saw included patients who required emergency operating theatre facilities, ICU, the interventional suites, as well as looking at intra and inter-hospital transfers of urgent neurologically injured patients. And like I said, in the main OT or in NCID OT, it is a negative pressure system. It's a separate ventilation system to prevent exposure to the rest of the staff and non-COVID patients. The decision was made whether this patient needed to be housed in the main block ICU versus the NCID ICU. The only thing that was different was that our interventional suites were in the main block, and these were not specific only for the COVID patients. And therefore, just like the AHA guidelines, what we had to do was we had to prophylactically intubate anybody who required an EVT before transporting these patients down. And therefore, the intubation would be done in full PPE in a special or specific OT or ICU setting before being brought down to the neuro interventional suites. I'm stuck, sorry. I can't move it anymore. We wanted standardized measures for our neurological emergencies, but also adjusted some of our stroke protocols to ensure that our patients receive timely care and also to limit provider and patient exposure. Like I said, we had a lot more use of telecommunication and telemedicine in this era. We also had to make decisions about the timing of testing when. So if the patient was not an urgent test, we might decide to wait until a patient was de-isolated before we redid a test. We had to reorganize some of our manpower norms to ensure that we could actually man both neuro ICU as well as outbreak ICU. And our off-care site that was secure was our NCID ICU. The care pathways still remain the same with some adjustments, but internally we wanted to limit campus movement to prevent cross infection of our patients. And so also taking into account that some of our patients may also be given a QO order as well. Now, this is also another pictorial diagram to know that if you need to get from May OT in Biennial block to NCID OT, it actually is almost a 1 kilometer route and you may get lost along the way. And so these are signposted to allow people to be able to get from one OT to another quite quickly and safely. And so the COVID-19 pandemic does present substantial challenges for us in terms of acute stroke therapies, because these patients seem to be more vulnerable to a brain ischemia, but we also need to spend time and potential delays because we need to screen them for acute stroke symptoms, but we also have to impose additional protective measures to promote infection control, both from a pre-hospital phase even up to hospital institute. And we also want to make sure this does not happen with substantial delays. So in summary, we should have protocols for managing neuro complications in this COVID pandemic. And I think even if we have the next virus X, this will keep us in good state. This needs to be with rapid, thorough evaluation of patients, but also minimize the risk of viral exposure to other staff and patients. And although less than 5% in the literature do have neurological complications, these occur in patients who are critically ill and for which a timeline is very important. And like I said, time is brain for all neurological emergencies, and hopefully we can get the best outcome for our patients. Thank you.
Okay, thank you, Dr. Wang Yulin, for the excellent presentation on handling neurologic cases mainly regarding stroke during the COVID-19 pandemic. Yeah. For participants who will ask the question, please submit via question and answer chat. Okay, for the second speaker, department from Ireland Hospital, Surabaya. I think we all know her very well. The topic that will be present are hyperthermia in neuro-intensive care, temperature modulation. Okay, for Prof. Siti Khasna, time is yours.
Thank you, Mr. Chairman. Allow me to speak in bahasa Indonesia.
Monggo, Bro.
Dan mengingatkan menurut pemberitahuan yang ada, pada plenary tidak ada tanya jawab.
Terima kasih, Bro.
Ya. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Judul yang diberikan pada saya oleh panitia adalah Hyperthermia in Neuro-Intensive Care. Slide. Sebelum saya masuk ke materi, maka ada baiknya untuk menyamakan pendapat tentang hyperthermia dan fever, karena seringkali keduanya ini, kedua terminologi ini digunakan pada keadaan yang sama, yaitu peningkatan suhu tubuh. Padahal secara definisi keduanya berbeda. Fever itu adalah suatu respon fisiologis terhadap stres yang diatur melalui jalur pirogenik dan antipiretik dalam tubuh sebagai hasil dari peningkatan set point di hipotalamus. Jadi fever adalah bagian dari respon adaptif fisiologis dari tubuh. Sedangkan hipertermia merupakan proses patologis kenaikan suhu tubuh di atas normal yang tidak ada kaitannya sama sekali dengan hypothalamic set point. Nah, biasanya kita kacaukan kalau panasnya itu tinggi dinamakan hipertermi. Kalau tidak terlalu tinggi, fever. Jadi barangkali ini yang harus disetujui bersama. Secara keseluruhan, slide. Secara keseluruhan dilaporkan bahwa lebih dari 50% pasien di ICU mengalami pireksia tidak disebabkan oleh infeksi. Insiden dari pireksia yang tidak disebabkan infeksi ini di neuro intensive care dan di neurosurgical intensive care itu antara 23 sampai 47%. Dan laju episode febris yang paling tinggi ditempati oleh subarachnoid hemorrhage, diikuti oleh cedera otak traumatik, dan selanjutnya oleh perdarahan intracerebral. Sedangkan yang tidak diketahui penyebabnya itu diperkirakan 28%. Nah, hipertermia di nicu yang tidak diketahui penyebabnya setelah semua kemungkinan disingkirkan, slide berikut. Slide berikut. Dinamakan hipertermia sentral atau hipertermia neurogenik. Keadaan ini pertama kali ditemukan pada tahun 1936 pada kucing dengan kerusakan hipotalamus anterior yang mengalami hipertermi. Kemudian pada tahun 1940 dilaporkan terjadinya hipertermi tanpa disertai infeksi pada pasien yang mengalami lesi pada hipotalamus setelah intervensi pembedahan. Sementara itu pada tahun 1977, laporan dari percobaan binatang dilakukan lesi pembedahan pada hipotalamus anterior dan regio preoptik. Maka akan timbul hipertermi tanpa disertai bukti-bukti adanya infeksi. Kemudian lesi yang sama pada tempat yang sama itu juga ternyata meningkatkan level prostaglandin lokal. Selanjutnya, pada penyuntikan prostaglandin ke bagian anterior hipotalamus yang intak, juga menghasilkan respon hipertermi yang sama. Sehingga dari sini diambil simpulan bahwa yang mengantarai terjadinya hipertermi itu adalah prostaglandin, bukan lesinya sendiri. Masih dibuktikan lagi bahwa pemberian prostaglandin inhibitor ternyata dapat menghilangkan hipertermi yang disebabkan oleh lesi pada hipotalamus bagian anterior. Slide berikut. Jika di neurointensive care didapatkan suhu tubuh lebih dari 38,5 derajat, maka harus dibedakan apakah ini fever atau hipertermi. Fever sendiri dapat disebabkan baik oleh infeksi maupun yang non-infeksi. Jadi kausa infeksi maupun non-infeksi. Sedangkan hipertermia pada umumnya adalah karena kausa adanya gangguan endokrin, misalnya pada tirotoksikosis, atau reaksi obat-obatan. Namun, didapatkan pula bahwa hipertermia itu disebabkan oleh cedera otak akut, baik itu berupa cedera otak traumatik, SAH maupun stroke, baik iskemik maupun hemoragik. Sumber hipertermi potensial yang mengikuti cedera otak traumatik tadi bervariasi juga, bisa berasal dari febris yang disebabkan oleh infeksi. Misalnya pasien ini dengan aspirasi pneumonia atau inflamasi, atau sampai hipertermia yang diantarai oleh yang dinamakan post traumatic hyperthermia. Jadi tidak ada infeksi. Berikut. Pada slide ini dapat dilihat gambaran skematik dari interaksi neuroimun yang diperkirakan akan menghasilkan febris atau pireksia. Jadi adanya diawali dengan stimulus eksogen seperti inflamasi atau infeksi, kemudian akan merangsang pelepasan sitokin endogen dari makrofag atau mikroglia. Sitokin dalam sirkulasi akan masuk ke organ di sekitar ventrikel otak dan mengaktifkan jalur OX2 dan merangsang produksi prostaglandin E. Prostaglandin ini akan masuk menembus sawar otak ke otak, kemudian akan men-trigger komponen dari respon fever tadi, yaitu komponen endokrin, komponen otonomik, dan behavior. Nah, pada hipertermia, gambaran skematik ini sama seperti pada fever, hanya pemicunya bukan infeksi tapi cedera otak akut. Berikut. Nah, jika ada hipertermia apapun penyebabnya terjadi bersamaan dengan respon akut terhadap cedera otak traumatik, maka respon yang sama akan terjadi sehingga menghasilkan sinergi dan potensial meningkatkan kerusakan neuron. Jadi hipertermia akan memberi dampak pada CNS, yaitu memperburuk cedera otak yang sudah ada. Mekanismenya dalam memperburuk ini diperkirakan dapat akibat efek seluler, yaitu hipertermi menyebabkan kerusakan sel langsung, kemudian menghambat transport protein membran, transmembran, dan mempengaruhi stabilitas membran. Rusaknya transmembran ion channel ini akan menyebabkan penumpukan kalsium dan natrium dalam sel dan terjadilah edem dan aktivasi jalur apoptosis. Atau efek lokal, yaitu hipertermia menyebabkan peningkatan sitokin pro dan antiinflamatori yang men-trigger terjadinya perubahan yang cepat pada pembuluh darah organ seperti terjadi dilatasi kapiler atau stasis dan ekstravasasi. Keadaan ini dapat terjadi pada hipertermia yang berlangsung selama 30 menit dengan suhu lebih dari 40 derajat. Yang terakhir adalah efek sistemik, yaitu terjadi perubahan pada cerebral blood flow dan CMRO2. Meskipun mekanisme belum jelas, tetapi dari penelitian didapatkan bahwa setiap kenaikan 1 derajat Celcius suhu akan menyebabkan perubahan cerebral blood flow 6-7%. Namun, apabila suhu meningkat sampai 40 derajat, maka cerebral blood flow akan turun di bawah baseline dan akan terjadi pula kerusakan blood-brain barrier. Berikut. Nah, berdasarkan itu, maka haruskah kita itu melakukan terapi pada atau fever atau hipertermia, dan bagaimana dampak dari terapi tersebut. Berikut. Mengingat bahwa terbukti hipertermi itu memperburuk kondisi CNS sendiri, maka modulasi suhu itu perlu dilakukan. Dapat dilakukan dengan cara farmakologi, yaitu dengan antipiretik, atau non-farmakologi dengan cooling, pendinginan baik internal maupun eksternal cooling. Dapat dilakukan pada awalnya, yang telah dilakukan adalah pada fase akhir, kemudian setelah itu orang mencoba untuk memberikan cooling itu pada fase awal untuk mendapatkan diperkirakan akan menyebabkan menghasilkan neuroproteksi. Berikut. Ini salah satu contoh dari hasil penelitian RCT yang melibatkan 41 orang pasien dengan menggunakan paracetamol dengan kontrol normal saline, dilakukan selama 72 jam. Tampaknya bahwa pemberian paracetamol intravena 6 gram per hari tidak dapat menurunkan suhu tubuh secara signifikan, namun secara klinis tidak mempunyai efek. Antipiretik ini akan memblok proses dengan menghambat sintesis prostaglandin E yang diantarai oleh siklooksinase tadi di otak dan menghasilkan penurunan set point dari hipotalamus. Nah, efektivitas antipiretik ini sangat erat kaitannya dengan kondisi di mana termoregulasi itu masih entak. Oleh karena itu, antipiretik tidak efektif untuk pasien dengan cedera otak yang mekanisme termoregulasinya rusak. Jadi misalnya pada pasien cedera otak yang didapatkan cedera pada senter termoregulasinya sendiri, maka penggunaan antipiretik ini tidak akan ada gunanya. Berikut. Pengelolaan hipertermia non-farmakologik dengan pendinginan, baik eksternal maupun internal, sampai saat ini, sebetulnya terapi ini sudah dilakukan untuk pasien dengan pasien cedera otak traumatik dengan tekanan intrakranial yang membandel, sesuai dengan guideline dari Brain Trauma Foundation. Namun masih diperdebatkan, terutama pada dari aspek outcome dan efek negatif untuk pasien. Meskipun demikian, pada umumnya hampir semua peneliti berpendapat bahwa terapi hipotermi ini menjanjikan, sehingga masih akan dilakukan penelitian-penelitian lebih lanjut. Skema ini dari Yokobori dan kawan-kawannya yang menggambarkan skema mekanisme cedera otak iskemik reperfusi yang disesuaikan dengan akut SDH yang mewakili cedera otak traumatik. Di sini diprediksi tempat-tempat di mana titik-titik yang efektif untuk terapi hipotermi pada kaskade ini, baik pada fase iskemi maupun pada fase reperfusi. Berikut. Pada tahun 2016, Sevi dan kawan-kawan mempublikasikan hasil analisis berbagai RCT tentang manajemen hipotermia pada cedera otak traumatik seperti terlihat pada tabel ini. Didapatkan 4 RCT besar dimulai dari Clifton tahun 2001 dengan National Acute Brain Injury Study Hypothermia yang pertama. Kemudian tahun 2011 itu tadi hipotermia yang kedua oleh Clifton juga. Tahun 15 kelompok dari Jepang, multi-center trial, dan yang berikutnya adalah Andrews, juga suatu multi-center dari Eropa, Euroterm. Nah, tampaknya dari keempat penelitian tersebut yang meliputi lebih dari 1.100 pasien menunjukkan bahwa hipotermia tidak efektif dalam memperbaiki outcome klinis dari pasien COPD. Penggunaan terapi hipotermi ini tidak efektif untuk menurunkan, digunakan pada pasien dengan tekanan intrakranial yang tinggi, sesuai dengan yang sudah saya sebutkan tadi pada guideline. Berikut. Nah, penggunaan terapi hipotermia di klinik pasca COPD yang sebetulnya sudah lama digunakan, yaitu pada fase yang lambat pada late itu. Di sana diharapkan terjadinya selain penurunan, jadi mengurangi hipertermi, kemudian juga untuk memperbaiki blood-brain barrier, mengurangi edema, dan menghambat inflamasi. yang tadi dikatakan bahwa outcome-nya sama saja, tidak ada perbaikan. Kemudian orang bergeser bagaimana kalau terapi hipotermia ini dilakukan pada fase awal, yaitu beberapa menit sampai 72 jam pertama. Dengan harapan terjadi neuroproteksi, yaitu penurunan cerebral metabolic rate, oksigen, menghambat eksotoksisitas, menghambat kalsium influx, dan dengan jadinya diharapkan menghambat proses apoptosis. Jadi dua penelitian yang mempunyai tujuan yang berbeda dengan hipotermi ini, yaitu kalau dilakukan pada fase akut adalah untuk neuroproteksi dan pada fase yang lambat itu untuk terapi. Nah, dari berbagai penelitian tentang hipotermi untuk neuroproteksi ini, sampai saat ini belum didapatkan hasil yang menjanjikan, sehingga untuk sementara tidak dianjurkan dilakukan di klinik. Berikut. Nah, dari bahasan ini dapat disarikan sebagai berikut, bahwa febris atau fever dan hipertermi itu sering dijumpai pada pasien yang dirawat di NICU, sementara febris merupakan proses fisiologis, hipertermia adalah suatu proses patologis yang tidak ada kaitannya dengan set point hipotalamus. Hipertermia setelah cedera otak akan memperburuk outcome dan mempunyai saham terhadap terjadinya cedera otak sekunder. Hasil penelitian pada manusia dan hewan coba menunjukkan bahwa luasnya cedera otak berkaitan dengan waktu timbulnya hipertermi. Makin dini timbul hipertermi, maka makin jelek outcome-nya. Berikut. Maka dari sinilah menurunkan suhu tubuh itu menjadi tujuan utama dalam pengelolaan pasien hipertermi di NICU. Terapi non-farmakologi tampaknya menjanjikan untuk dijadikan terapi pilihan. Non-farmakologi menjadi pilihan untuk menurunkan tekanan intrakranial pada kasus tertentu, tetapi gagal untuk menurunkan mortalitas dan outcome klinis yang tidak diharapkan. Sedangkan penggunaan profilaktik hipotermia dan diberikan dini sebagai neuroproteksi masih mengundang perdebatan. Sebetulnya banyak penelitian tentang hipertermia ini adalah karena dirasakan bahwa konsideran yang digunakan untuk terapi hipotermi pada cedera otak di traumatik untuk cedera otak dari Brain Trauma Foundation itu kurang kuat untuk dijadikan dasar. Sekian dan terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Matur suwun Prof. Siti, thank you Prof. Siti atas presentasinya yang luar biasa. Dan in this plenary, there is no direct question and answer. Yeah. Participant who will ask about the topic that presented by Dr. Wang Yulin and Prof. Siti Hasna can be submitted through the committee. Now I can make a summary from the presentation of Dr. Wang Yulin. Stroke during the COVID-19 pandemic is a challenge in itself in emergency management in ports in operating theater and the ICU, and also transportation to the service center. From Prof. Siti Khasna explained that hyperthermia is a pathological increases in body temperature that is not associated with increase in the hypothalamic set point. Okay, thank you for Dr. Wang Yulin and also for Prof. Siti Khasna for their excellent presentation. Hopefully, it will useful for all of us. In this, I finish the session. Thank you for all participants. Assalamualaikum warahmatullahi wabarakatuh. Time I will return to Master of Ceremony.
Thank you, speakers and moderator, for the first session of plenary lecture. Before entering the second session, we will introduce those who act as speakers and moderators. We have 4 speakers: Professor Kwek Tong Kiat from Singapore,
Dr. Iwan Abdurrahman, Neuro Anesthesiologist Consultant, Master of Public Health from Indonesia,
Dr. Pim Wang Sok Plong from Thailand,
Professor Dash from India.
and for the moderator, Dr. Muhammad Dwi Satrianto, Neuro Anesthesiologist Consultant, Master of Public Health.
Before we hand over the host of the session to the moderator, allow us read a little CV about him. He was graduate from Medical Faculty of Trisakti University. Then he continued his study as anesthesiologist and advanced his study as neuro anesthesiologist consultant at Pajajaran University.
Now, he serves as staff consultant Clinical Medical Science Department, Faculty of Medicine and Health Science in Universitas Abdurrahman Pekanbaru, Riau.
We welcome you, speakers and moderator. To Dr. Dwi Satrianto, the time is yours.
Thank you. Nice introduction from Master of Ceremony. Good morning. Assalamualaikum warahmatullahi wabarakatuh. For our teacher who we love, ladies and gentlemen and colleges, thank you for opportunity given to me. My name is M. Dwi Satrianto from Pekanbaru, Indonesia. In this session, neurological emergency, I was given the task of moderator, and will last for approximately 2 hours. In this session, I was introduced early from ceremony. I will introduce again that we have 4 speakers, and the title of topic that will presented by them. They are, for the first speaker is from Kwek Tong Kiat from Singapore. The second speaker is Dr. Iwan Abdurrahman from Indonesia. The third speaker is Dr. Primwan Sok Plong from Thailand. And the last speaker is from Das, Professor Das from India. And the end of the event, we will discussion about this topic. And I will read the question entered in the question and answer box. Therefore, question can be submitted in the question and answer box. Thank you. Before the presentation for the first speaker from Professor Kwek, allow me to read a part of his curriculum vitae. Prof. Kwek Tong Kiat is a senior consultant in the Department of Anesthesiology, Intensive Care, and Pain Medicine, and Assistant Chairman, Medical Board Clinical Development at Tan Tock Seng Hospital, Singapore. He also senior consultant to Minister of Health for National Disease Donor Program in Singapore. And the other, he is a regular examiner for the local Master of Medicine, Anesthesiology, Part 1, and the second examinations of the external examiner for the primary examination of the Hong Kong College of Anesthesiology. And he is the external faculty and examiner for the neuroanesthesia and critical care program at the University Pajajaran, Bandung, Indonesia too. Thus, part of curriculum vitae from Prof. Kwek. Furthermore, presentation from Prof. Kwek with the topic respiratory function and the mechanical ventilation topics. Prof. Kwek, we are happy you are here. The lecture stage is yours, please. Thank you.
Thank you very much, Chairman, for that kind invitation. I'm very happy to be here with everyone today. And let me thank the organizers for the kind invitation to participate in this conference. And let me congratulate the Indonesian Society for the success in organizing this meeting, which I think is important. And I'm glad that we have shown that life can go on and activities and educational forums like this can continue and we can collaborate. While we all prefer very much to see each other face to face, but on Zoom, I guess in these times, it is good that we carry on. So I'm really glad to be part of this symposium. So today I've been asked to speak on respiratory function and mechanical ventilation in neurocritical care. It's a topic that I suppose we all interact with every day when we manage our neurologic patients, where we know acute brain injuries can disrupt normal respiratory function. And our patients with acute brain injuries often will require mechanical ventilatory support or other forms of respiratory support, like non-invasive ventilation. And this arises because of the need often to protect and maintain the airway, and also to ensure optimal gas exchange, primarily to ensure that the PaO2 oxygenation and carbon dioxide tensions in our blood are well and optimally maintained. We also know of the impact that acute brain injuries can have on respiratory function. I've listed a number here. It's by no means exhaustive, but it does cover the broad spectrum of what we see often, from impairing respiratory drive to direct effects on the endothelium and epithelium, to effects on the heart with neurocardiac injuries, the broken heart syndrome or Takotsubo cardiomyopathy, which many of us are familiar with, or even to the effects of prolonged immobility, which we know has very harmful effects on the patient as a whole, but on the respiratory function in particular. But given that there's only so much time, I'm going to focus the rest of my talk really on the impact of mechanical ventilation on brain function and what the current evidence is with regards to optimal management of a patient on mechanical ventilation, with a view to how that might or might not affect brain function. Now, we know that with positive pressure ventilation and increase in mean intrathoracic pressures, there have been concerns on how this might adversely affect intracranial pressure and in turn cerebral perfusion pressure and cerebral blood flow. So I'll show you what the current evidence is on this. Secondly, we know that lung protective ventilatory strategies is pretty much standard of care today in all our ICUs. But yet, are those safe in patients with acute brain injury? And what are the safe O2, CO2 targets? Can we safely use PEEP? What about recruitment maneuvers? So I hope I can cover some of these in the remaining time that I have this morning. Some of my comments will be taken from this recent consensus conference of the European Society that was published recently in 2020. And I would strongly encourage you to take a look at this paper, which has many useful recommendations based on the current state of evidence or lack thereof. Now we know of the effects of carbon dioxide and how it can affect the autoregulation of blood flow. This is an area very familiar to all of us as neuroanesthesiologists and neurocritical care doctors. And we know that increased or decreased carbon dioxide tension in the blood can cause changes in the caliber of the cerebral arterioles and in turn cerebral blood flow. In fact, till very recently, it used to be a therapy that was often employed in the control of ICP, although we do that much less now. However, the concern has always been that hyperventilation causing maybe even moderate hypothermia. We're not talking about severe hypothermia, but even moderate hypothermia has the potential to cause severe ischemia in parts of the brain, sometimes unknown to us because it's not something that we can easily measure at a bedside. So in this publication, by now almost 20 years old, but still illustrates it very well. If we were monitoring the bedside parameters, carbon dioxide tension, ICP, CPP, and even if one were to measure SjVO2, looking at the amount of the saturation of blood returning from the brain, and this is a perfusion scan showing the overall perfusion in the brain, with the darker colors being lower flow and the brighter white colors being higher flow. You can see that on the scale on the right here. That if one were to hyperventilate the PaCO2 from 35 down to 26, and you can see that ICP would seem to move favorably, CPP would seem unaffected, SjVO2 would clearly still be within the acceptable range of above 50, 55. On the perfusion scan, the picture looks quite different and rather worrying, that the areas with very low perfusion has markedly increased. And this is what we have known for a number of years now, the potential harm that can arise from excessive ventilation and keeping our PaCO2 tension lower, significantly lower than normal. So I think today, the recommendation is for us to maintain normal capnia as a default in the absence of any need to change intracranial pressure, and to use any degree of hyperventilation, firstly as a very short-term basis, and secondly in a tiered fashion with consideration of the risk-benefit of doing so. I think with oxygen tension, I think is much less controversial. We all know that it is appropriate and right to avoid hypoxemia. There was a little bit less known about avoiding hyperoxia. There was even some suggestion that it might be a good thing. But I think today it is recommended to avoid. It is a strong recommendation, although the quality of evidence is poor. As I said earlier, lung protective vent strategies have become standard of care in our ICUs today. And that often involves a combination of using lower tidal volumes, usually 6 to 8 mils per kilogram lean body weight, and using higher PEEPs to keep the lung units open and to avoid atelectasis. There have been many studies published, and I'll just highlight one here that was in the JAMA recently. And this is in a group of non-head injury patients and without acute lung injury or severe acute lung injury. And you can see here that there is clearly a benefit with regards to lower tidal volumes favoring avoiding lung injury. Also, lower tidal volumes favoring mortality. There's a mortality benefit, lower incidence of pulmonary infection, and lower incidence of atelectasis. But I think what remains unknown is whether a lung protective ventilatory strategy is safe in patients with acute brain injury. There are concerns that this might result in hypercapnia, and for the potential effects on ICP, as I've explained in the earlier slides, and whether higher PEEP might have potential harmful effects on cerebral venous drainage and in turn raise intracranial pressure. So let's see whether there are any evidence to guide us in this area. I must say there's very little, and I'll show you a few of the little that there is. This is a a prospective before and after study that was done in 20 French ICUs, where they looked at quite a large study, 744 patients. 391 were in their pre-intervention and 352 were post-intervention. The intervention here was the institution of a lung protective ventilatory strategy. So you can see here comparing pre and post, where the post are the darker circles. You can see that the tidal volume pre and post on days 1 to 5 of mechanical ventilation were lower, as was by design. This is just to show that they had achieved some separation between pre and post. You can also see that the PEEP levels used were slightly higher, from a mean of 4 to 5 to about 6 to 7 pre and post intervention. Now, they found that the incidence of intracranial hypertension, which they defined as an ICP more than 25, was no different pre and post intervention. You can see incidence was about 40% no difference. In addition, the incidents where they had to apply medical interventions to treat intracranial hypertension, from osmotherapy, barbiturate therapy, barbiturate coma to hypothermia, were again no different between the two groups. So it would seem from this somewhat indirect evidence that at least a lung protective vent strategy seems to be safe or to do no harm. What about intracranial pressure being affected by use of PEEP? So this is a fairly old study, a small group, 18 patients in a tertiary neuro ICU. And they looked at 4 levels of PEEP from 0 to 15 in a group that had normal intracranial pressure and another group that had high intracranial pressure. And they found that there was some significant difference between 0 PEEP to 10 or 0 PEEP to 15, but no difference between 0 PEEP to 5. So there was a slight change in ICP. But as you can see here, there's still single digit. While it might be a statistically significant change, I'm not sure this is clinically significant. Certainly on the CPP end, there was no significant difference, and even eyeballing it, it doesn't look different. In the group that had a high ICP, you can see here that the baseline intracranial pressure is higher. And here they found no difference, reassuringly so. One would have been more concerned that in this group there might have been some difference, but it's comforting to know that it resulted in no difference. So at least from this small study is reassuring. Moving to something a bit more recent, again, another prospective trial in the neuro ICU, this time in traumatic brain injury patients with ARDS, again, a fairly small cohort of 20 patients. And this is a study from Brazil. You can see here that the mean GCS was fairly low, around 5, ranged from 3 to 8. Fairly young patients, as would be expected, being traumatic. You can see the PF ratio is 144. So these were patients with clearly acute lung injury. They also measured brain tissue oxygen tension. You can see that the baseline on the Lycox monitor was fairly good. It's 26 for mean, and ICP was not raised in this group. And so when the PEEP was raised from 5 to 10 to 15, you can see that actually the change in ICP was unremarkable and not statistically or clinically significant. There's also no change in the CPP. The only change that they found that was statistically significant was actually a slight improvement in the pulse oximetry oxygen saturation. And that's not surprising because one would expect that with higher PEEPs that would happen, and which was exactly the same finding they found in the brain tissue oxygen tension, where it actually improved oxygenation and the oxygen tension monitored actually increased at higher PEEP. So again, a negative study in terms of harm, and again, reassuring. This is an even more recent study, a larger study from Boston, again in patients 18 years and above, but it's a retrospective study, so probably not as good data as a prospective study, but the large study, 341 patients with a very large number of PET observations of PEEP and ICP. And they divided the patients into those with no lung injury, where the PF ratio was more than 300, to those with mild moderate and severe, with those with PF ratio less than 100, and these were in between. And you can see that in terms of the intracranial pressure and the effect of increasing PEEP all the way to 25, actually the gradient of this is fairly flat. The correlation ratio for these are insignificant, except for the red line, which you can see is the most severe group. So there's a suggestion that for the most severely injured, those with the most severely injured lung with acute respiratory distress syndrome, there is a concern that it might affect ICP, but less so for those with less severe injury. So this is the same data, but shown on a tabular form. They did some adjustment between the unadjusted and adjusted PEEP for tidal volume, minute ventilation, respiratory rate, and so forth. And in the adjusted group, when they compared, as I've shown you in the graph earlier, it was only in a severe lung injury group where they showed a statistically significant difference. So I suppose on aggregate, the evidence would suggest that there's some uncertainty in the severe lung injury group, but in all the others, it appears that PEEP could be applied safely. What about alveolar lung recruitment maneuvers? You can, as we all know, alveolar recruitment maneuvers can be done in various forms. I kind of shown two of the more commonly applied forms. One where one does a stepped up PEEP all the way up to 40 for 40 seconds. Some might do 30 for 30 seconds. And then after that, a gradual decrease in the CPAP level. Or do intermittent large tidal volumes for a number of maybe 5 to 10 breaths. But whichever method you use, unfortunately, there is very little evidence. And at least in that consensus conference, they could make no recommendation on its use. So I think at the moment we still await further trials, but we are somewhat in the dark with regards to alveolar recruitment. My suggestion is, if you have an ICP monitor on board, and if you do need to do a recruitment trial, I suppose you could do one and monitor the ICP closely. What about prone positioning? And I'm sure many of you in the midst of this COVID pandemic have used prone positioning quite a lot on our patients. And so in patients who have acute brain injury with some degree of lung injury, and obviously that is why we're even thinking about prone. If the patient's ICP is normal, then I think the current recommendation is that it can be considered and applied if needed. And this is a fairly strong recommendation. However, if the ICP is elevated, I think it is unknown. There's no recommendation. And again, I would say that if it really needs to be done, is potentially life-saving, and you do have an ICP on board, one can consider, but do it cautiously with ICP monitoring. If you don't have ICP monitoring, then I guess it will be difficult to know which of these arms you fall into. So broadly, in summary, I think for acute brain injuries today, I think if there's no lung injury or there's no severe lung injury, if the ICP is normal, then I would think that the regular lung protective strategies with our usual PEEP can apply. In those with no lung injury, the intracranial pressure is already raised. At least based on some studies, there might, in the more severe group, potentially cause PEEP. So one might need to be more cautious and to monitor the intracranial pressure closely. If we find that in that particular patient, ICP seems to be unaffected by the PEEP, then I guess it could be done more liberally and quite safely. But if there is evidence that it might be raised, then one needs to be judicious in the use of PEEP. In a group that has ARDS, but the ICP is normal, then I think the lung protective strategies can be applied as well, and there's some evidence that this might be safe. But again, if the intracranial pressure is already raised, then I think there's no real evidence to guide this. So in conclusion, and thank you for your attention up to this point, unfortunately in this area of mechanical ventilation in acute brain injury patients, on what are the safe practices in the presence of decreased intracranial compliance, there is a general lack of robust scientific evidence to guide therapy. And I think we await more clinical trials to guide us in this area. I think at the moment, we can recommend that even in this group of patients, if the ICP is not elevated, lung protective ventilatory strategy can be applied with reasonable safety. And the usual caveats of avoiding hyperoxia, hypoxia, and normocapnia remain unchanged. So with that, thank you very much for your attention. My congratulations again to the organizers, and I look forward to your questions later on in the Q&A segment. Thank you very much.
Thank you, Prof. Kwek. That's very interesting and very open to our insights. For the second speaker, I would like to invite Dr. Iwan Abdurrahman, neurologist consultant, as the second speaker. He is from Indonesia. I read a part of his curriculum vitae. Dr. Iwan has completed his doctor education to consultant at the University of Pajajaran, Bandung. Currently, he is a lecturer and consultant of neuroanesthesiology at the Faculty of Medicine, University of Pajajaran, Bandung, Department Anesthesia and Intensive Care, Hasan Sadikin Hospital, Bandung. Currently, Dr. Iwan served as the first secretary at the Central Board of Indonesian Society of Anesthesiologists Intensive Therapy, Perdatin. And he is a hospital accreditation surveyor now. Furthermore, the presentation will be conducted by Dr. Iwan Abdurrahman with the topic cardiac complication in neurocritical care patient. Dr. Iwan, the stage is yours, please. Thank you.
Thank you, Dr. Dwi. I want to share my presentation, but okay. First, I want to thanks to the committee and the professor for the chance for me this morning. My topic is about cardiac complication in neurocritical care patient. First, I want to show you an example case when you are working on the ICU and from the emergency department. There is a 59 years old female with a pre-medical history of hypertension and then transient ischemic attack. And on the previous, she has left CA transfer, she left CAA, and the patient was transferred from an outside hospital with a left parietal ICH. Apparently, the patient had a massive migraine at home, then was unable to move her right arms or right hands. Emergency medical service was called, and when they arrived, she had developed facial drops and slurred speech. The outside hospital gave the patient an IH stroke scale of 6 during her emergency department stay there. The patient degraded to a GCS of 7 and she was intubated. A CT scan show a left parietal ICH with 4 mm shift. You can see the CT scan. And then when you enter the room, you see an awake woman arousable with 5 strength on the left side, but densely plegic on the right. Patient has right facial drop, but follows command. The patient is admitted to the neuro ICU, has a follow-up CTA showing no change the size of the ICH. You do a cardiac assessment on arrival to the ICU and find an ejection fraction of 25%. On apical four chamber view, you can see as on the video, And then on the short axis, you can see this is very unexpected as the patient has no cardiac disease in her history. A bedside chest X-ray shows massive flash pulmonary edema, and lab work shows a troponin of 1.52. Also very unexpected. You start the patient on dobutamine and elastic drip for presumed cardiogenic shock and heart failure. You can see her EKG. So what's going on here? Is the heart failure or red herring, or a reaction to the head bleed? What do you have to watch out for? If you say this is an example of the voodoo death, the voodoo death was first published by Cannon et al. In 1942. The mechanism proposed by Cannon et al. To explain this cardiac death was neurogenic, specifically a severe and persistent sympathoadrenal response. And then Levi et al. Performed a series of experiments on cat and demonstrated that sympathetic activating maneuver such as intravenous adrenaline administration, electrical stimulation of sympathetic cardiac nerve, or emotional stress, all of which trigger ventricular fibrillation. And then Berger et al. Reported a case series of patients who died during seizures and were found to have myocardial with normal coronary vessels. In animal models, myocardial without involvement of coronary vessels could be produced by imparting stress to metabolically deranged rats. And then Raps et al. Also demonstrated that reserpine, a drug that blocks catecholamine release from presynaptic adrenergic nerve terminals, prevented distress-induced lesion. All of these findings in animals and clinical studies point towards sympathetic overactivity, either due to stress or severe neurologic damage, which initiates a process that culminates in release of excessive catecholamine at cardiac postsynaptic adrenergic receptor. The autonomic nervous system is a widespread network of nerves that connects central nervous system to the visceral organs. This forms a central neuronal network that controls vital function. Sensory receptor in the heart rate distributed throughout myocardial, pericardial, epicardial tissue, and at the junction of atria and groove veins. These receptors are activated by pressure in the heart chambers, and impulses are transmitted predominantly via vagal afferent at nucleus of solitary tract in the medulla. NGS also receive afferent from baroreceptor, chemoreceptors, and skeletal muscle receptors. Afferent connection from sensory receptors of heart travels via 9 and 10 cranial nerves to nucleus solitary tract in medulla. Periventricular nucleus of hypothalamus is an integrating center as it has reciprocal connections with autonomic nuclei from brainstem, other hypothalamic nuclei, and from cortex. Afferent autonomic pathway to the heart again shown are reciprocal connection of periventricular hypothalamus with other central autonomic nuclei in cortex, hypothalamus, brainstem, and spinal cord. Hypothalamus with sympathetic afferent from higher centers descend to intermediolateral columns of upper thoracic spinal cord, whereas parasympathetic signal travels via vagus nerve. There is an intrinsic network of cell bodies with interconnection fiber, collectively known as cardiac ganglionic plexus or CGP. Parasympathetic stimulation interact with sympathetic stimulation to counter various aspects of arrhythmogenesis. This is the overview of autonomic receptor and action of cardiac neurotransmitter and neuromodulator. As you can see, neurotransmitter and or modulator, which are norepinephrine and epinephrine, and then acetylcholine, nitric oxide, has active intestinal polypeptide, neuropeptide Y, and intermedin. The paravertebral sympathetic ganglion receives descending input from higher centers, which exit central nervous system via upper 5 thoracic spinal cord segment as preganglionic fibers. Parasympathetic nerve supply to the heart has its preganglionic neurons located dominantly in nucleus ambiguous and to lesser extent in dorsomedial nucleus of vagus. Sympathetic input to the heart comes from neurons in the intermediolateral column at T1 to T5 level of spinal cord. This IML column is modulated by descending neurons from rostral ventrolateral medulla and paraventricular nucleus of hypothalamus. Parvocellular neurons in PVN of hypothalamus, also known as proautonomic neurons, are the only autonomic neurons which are recipient of autonomic afferent and send both sympathetic and parasympathetic afferent to other autonomic centers. PVN is considered to be the control center, modulating and optimizing balance between the opposite response. Other hypothalamic nuclei that play an important role are anterior and lateral hypothalamic nuclei. Anterior hypothalamus has parasympathetic, whereas lateral hypothalamus has a sympathetic influence. In higher cortical center, especially the insula, control of sympathetic and parasympathetic outflow is lateralized in complex manner. Sympathetic was lateralized to the right insula and parasympathetic activity to the left. In the study, patient with stroke involvement of insula on either side was associated with excessive sympathetic activity, but was more pronounced in patient with right insular stroke. In animal studies, sympathetic chronotropic activity was found to be represented as rostral posterior insula, whereas parasympathetic chronotropy localized to caudal posterior insula. Several different mechanisms have been proposed to explain neurogenic myocardial dysfunction. The most widely accepted of this focal damage or dysfunction of CNS structures controlling autonomic outflow leading to sympathetic overdominance, which in turn affect myocardial rhythm and integrity. This is the pathophysiology of autonomic cardiac function. You can see either in structural damage or the excessive stimulation can cause myofibril necrosia by this process. And then myocardial autonomic innervation and its impact on myocardial pathophysiology depend on multiple factors. Electrographically, this duration is represented by QT interval in example summation of duration of QRS complex, ST segment, and T waves. APD is maintained transiently as calcium flows in through L-type calcium channels. At the ends of APD, delay rectified potassium channels slowly open, leading to kalium efflux, descending APD by restoration of polarized state. Based on the left ventricle is richly innervated by sympathetic nerve. Heng et al. Demonstrated that during sympathetic stimulation, there was shortening of APD that was significantly more pronounced at the base. Expression of delay rectifier potassium channel through which catecholamine produced shortening of APD was highly upregulated in basal area during sympathetic stimulation. Sympathetic stimulation via its effect on delay rectified potassium channel directly affect AP and reduce its duration. Heart rate, which is the sum of the I and APD, tends to increase as both of its components are shortened. Shortening of the I has another very crucial consequence. Through a feedback mechanism attempting to keep heart rate under control, this shortened the I will lead to APD prolongation of next cycle. This phenomenon known as restitution of APD. At rest, the curve of this relationship is relatively flat. With sympathetic stimulation, the slope of this curve steepens. If sympathetic stimulation is prolonged, and then it can initiate a rhythm disturbance known as epilaterance, and it can cause to malignant arrhythmia, which in electrographically, this process corresponding to prolonged QT interval. And AP alternance is a precursor of malignant arrhythmias and predictor of sudden death. Besides steepening of AP restitution curve via its effect on delay rectifier potassium channels, sympathetic stimulation also significantly alters calcium level by affecting L-type calcium channel. This leads to trigger activity as well as after depolarization, both of which are known precursor of ventricular arrhythmias. Increased sympathetic activity in the heart leads to phenomena known as sympathetic neural remodeling, where the nerve sprouting and then hyperinnervation of sympathetic nerve can cause malignant arrhythmia and sudden death. The oxidant stress have shown to increase sympathetic activity and further stimulate SNR by promoting expression of nerve growth factor gene. This mechanism can have potential therapeutic implication by activating antioxidant gene regulators, has shown to inhibit NGF expression and thus protect against ventricular arrhythmia. Excessive catecholamine exposure result in increased activity of cyclic AMP myocyte, causing excessive calcium influx. Actin-myosin interaction can be prolonged enough to overwhelm their physical integrity. Severe and prolonged catecholamine stimulation is well known to produce myofibrillar degeneration and contraction band necrosis. Characteristically located in subendocardium, these band necrotic lesions are known to produce malignant arrhythmias by involving the conducting tissue. In patients with acute stroke, repolarization abnormalities, particularly QTC prolongation, were common. Goldstein et al. Found new QTC prolongation to be present in 32% of the patient compared to 2% of control. In study of 150 patients with stroke, new T wave inversion and U wave were present in 15% of patients with acute stroke. These T wave are sometimes referred to as cerebral T wave, are defined as a T wave inversion more than 5 millimeters. This is clinical and electrographic cardiac events, a comparison between ischemic and hemorrhagic strokes. Some are most in spontaneous ICGs, ICH, and some are most in ischemic strokes. You can see above the incidence of cardiac events and below the common EKG changes. Sudden and cardiac, sorry, I will skip this slide. Overview of neurogenic cardiac dysfunction. The autonomic mediated abnormality can manifest as cardiac conduction disturbance and myocardial inotropic dysfunction. And you can see the proposed pathophysiologic mechanism and the clinical spectrum and disorder. You can see that there is a changes in heart rate and then loss of heart rate variability, EKG repolarization abnormality, elevation of cardiac enzyme, ventricular arrhythmia, and then sudden death. On myocardial inotropic dysfunction, you can see clinical spectrum or disorder as stress-induced cardiomyopathy and neurogenic stone myocardium. Stress cardiomyopathy, first in 1980, Sebelin et al. Used the term of stress cardiomyopathy to describe myofibrillar necrotic lesion of heart found at autopsy of physical assault victim. And then Sato and colleagues from Japan reported a series of cases of potentially reversible cardiomyopathy mimicking acute anterior wall myocardial infection, and it's called Takosobu. In Japanese fisherman octopus pot, this cardiomyopathy that was transient and resolved over time was termed Takosobu cardiomyopathy, also known as apical ballooning syndrome or broken heart syndrome. In addition to emotional stress such as death of close family or friend, financial loss, or natural disaster, this cardiomyopathy also known to be precipitated by stress related to acute critical illness such as sepsis, acute chronic respiratory failure, and catecholamine infusion. Neurogenic stunned myocardium is described as a syndrome of acute left ventricular dysfunction triggered by an acute neurologic condition. NSM is a distinct subtype of stress cardiomyopathy. There is a direct involvement of neurocardiovascular regulatory areas precipitated by the acute neurologic condition rather than their secondary involvement as a result of stress, which is seen in TCM. This is the difference. And then this is the clinical features of Takotsubo cardiomyopathy and neurogenic stone myocardium. They're the difference on clinical features. And then the risk stratification and diagnostic workup. Demographic and historical data. Patients who are already taking angiotensin converting enzyme inhibitor or angiotensin receptor blockers were less likely to develop ventricular arrhythmia than those who were not on this medication before aneurysmal rupture. Female gender, which comprise overwhelming majority of TCM cases, is more prone to develop QTc prolongation after ACAH. Female gender and hypokalemia were identified as independent risk factor for QTc prolongation after ACAH. Patients who presented with a National Institute of Health stroke scale NIHSS of more than 10 had a higher rate of troponin elevation and ischemic changes in EKG compared to patients with NIHSS less than 10. Patients with higher Hunt and Hayes score after ASAH have a much higher incidence of left ventricular RWAs. Posterior circulation aneurysmal rupture was much more commonly associated with sudden death as compared to anterior circulation aneurysm. Intraventricular hemorrhage was found in 12 to 30 patients in ASAH who died before reaching the hospital. Insular involvement was independent predictive factor of ST depression. Insular involvement and the presence of intraventricular hemorrhage were independent predictive factor of QTc prolongation. Serial EKG studies or continuous telemetry recording along with an echocardiogram are extremely useful in the identification of patient at risk and diagnosis of NSM. Troponin T or I are commonly elevated in patients with acute stroke, even in patients with a pre-existing cardiac history or renal dysfunction. In patients with ASH, elevation of troponin I is highly sensitive and specific marker of neurogenic myocardial damage. In comparison to severity of myocardial dysfunction with low ejection fraction, troponin elevation is modest. This relatively modest elevation of troponin with severely low ejection fraction on 3D echo is SAH is suggestive of a neurogenic process rather than acute coronary syndrome. Therapeutic option and future direction. However, based on the unique pathophysiology of this condition, some specific therapeutic option can be suggested. First, centrally acting sympathetic blockers are a reasonable choice for patients with high blood pressure requiring antihypertensive treatment, which underlying risk factor for neurogenic cardiac dysfunction. Two small studies have shown safety and feasibility of implantable VNS with involvement in clinical parameter of CHF or primary cardiac origin. A number of pharmacologic agents frequently used in neurocritical care settings such as anticonvulsant, neuroleptic, or certain antimicrobial agents can prolong QTc interval and should be avoided whenever feasible, especially in patients at high risk of cardiac complication. Correction of hypokalemia and hypomagnesemia is prudent for the same reason. In the management of DCI after ASAH, inotropic agents are preferable over vasopressor for hemodynamic augmentation, especially for patients with NSM. Nitric oxide have been investigated in animal subjects during CPR after ventricular fibrillation-induced cardiac arrest and show improved success of CPR. Besides nitric oxide, intermedin, calcitonin gene-related peptide is another novel agent. Thank you. Thank you, Dr. Dwi.
Thank you, Dr. Iwan. Sorry. Okay. Thank you, Dr. Iwan, for your presentation. It's very applicative. There are some question in the question and answer box. Maybe later we can read this question. For the third presentation, it will be presented by Dr. Pimwan Soklung from Thailand. Here I read a part of his curriculum vitae. Dr. Pimwan, he is working at Department Anesthesiology, Neurological Institute of Thailand. His education, medical degree at Faculty of Medicine, Mahidol University, Thailand. He continue diploma, Thai board anesthesiology, and continue of neuroanesthesiology of the Royal College of the Anesthesiologists of Thailand. Certified in Neuroanesthesia Research Fellowship in the University of Washington, USA, and certified in the Fundamental of Intraoperative Neuromonitoring at the Larry Head Institute, USA. The academic position, he is the neuroanesthesiologist at the Department of Anesthesiology, Neurological Institute of Thailand, Ministry of Public Health, Bangkok, Thailand. Many publications he has published. One of the last published in the Thai Journal Anesthesiology 2020 with the title Outcome of Cardiopulmonary Resuscitation in Neurosurgical Patient in Prasad Neurological Institute. Furthermore, Dr. Pinwan will presentation with the topic is autoimmune encephalitis in the intensive care unit. Dr. Pimwan, the stage is yours, please. Thank you.
Thank you very much for Dr. Santianto for the nice introducing me.
Thank you, Doctor.
And thank you for the organization to invite me to be the speaker of this conference. Today, the topic that I will talk about is the autoimmune encephalitis, which is nowadays this is a very interesting topic because the incidence of it is increasing. Since I am not neuromedicine or immunologist, today I will focus on the neuroanesthesiologist perspective. I work at the Neurological Institute of Thailand on behalf of the Department of Medical Service, the Ministry of Public Health, so I don't have any conflict of interest from any medical company. This is the outline of the presentation. Today, I will talk about autoimmune encephalitis, the problem associated with the disease in the intensive care unit, such as status epilepticus, increased intracranial pressure, dysautonomia, respiratory failure, how-to management such as anti-epileptic drug, immunotherapy, antipsychotic drug, and prognosis of the disease. Autoimmune encephalitis most commonly affects in young people. The annual incidence of encephalitis is up to 12.6 per 100,000. 20 to 30% of the patients have an underlying autoimmune disease. Autoimmune encephalitis includes not only the syndrome due to a primary autoimmune response, but also those that are paraneoplastic. For primary autoimmune, the immune response directs against cell surface protein. The paraneoplastic autoimmune encephalitis resolves when systemic immune response to peptide antigen of the tumor, as well as response to peptide found in the brain. Paraneoplastic autoimmune encephalitis occurs from a known cancer or metastasis, and it can precede the detection of cancer or cancer recurrence. 38% have malignancy at the time of initial presentation. Most often have ovarian teratoma. So in female patients with the diagnosis of anti-NMDA receptor encephalitis, this patient should be screening. If the tumor was found, the tumor removed is the best therapy. This figure show the classic syndrome and characteristic of the neuronal autoantibodies. The different types of autoantibodies can cause different characteristics. The most common type of autoantibodies to cause autoimmune encephalitis is NMDA receptor. It usually affects in young female patients with acute onset of psychosis, with movement disorder, and dysautonomia. This may be why anti-NMDA receptor encephalitis is frequently initially misdiagnosed as a psychiatric disorder. Patients with autoimmune encephalitis always develop life-threatening conditions and often need intensive care unit. So early diagnosis, symptom type therapy, and critical care are necessary in the acute stage to improve the prognosis. The critical care for patients with anti-NMDA receptor encephalitis also need an interdisciplinary team, such as intensivist, neurologist, psychiatrist, cardiologist, nutritionist, physical therapist, social worker. Most patients have 5 stages of clinical presentation, including uploadermal phase. In this phase, patients usually have symptoms like viral infection that lasts for 2 weeks. Then psychotic or seizure phase, presented by the patient have rapid development of schizophrenia-like psychiatric symptoms and seizures. The unresponsive or catatonic phase. In this phase, patient may decrease level of consciousness with central hypoventilation, and this phase may frequently, this patient require mechanical ventilation. Hyperkinetic phase. Patient present with orofacial limb dyskinesia and autonomic instability. For gradual recovery phase, in this phase, the patient turns to recovery, but in some cases, the patient has a possibility of relapse. In patients who admit in the intensive care unit, the most common reasons are refractory seizure, autonomic dysfunction, hypoventilation, cardiac arrhythmia, and hyperkinetic crisis. The other complications that usually found in the intensive care unit are septic shock, organ failure, increased intracranial pressure, surgical complication, and psychiatric complication. Status epilepticus. This problem is the most common presentation. Refractory status epilepticus is the common cause of ICU admission, especially in patients with tumor. These patients have more incidence of status epilepticus, coma, and ICU admission. Patients can present in many types of seizure, such as non-convulsive, generalized, partial, and complex seizure. The treatment of autoimmune encephalitis patients with seizure need anti-epileptic medication, immunotherapy, and intensive care unit. The most common EEG background in autoimmune encephalitis is diffuse slowing or focal slow wave, mostly in frontotemporal regions. Patients with anti-NMDA receptor encephalitis have specific EEG patterns, such as excessive beta activities, extreme delta blush, generalized rhythmic delta activity. Extreme delta blush, or EDB, is the burst presentation of rhythmic beta frequency activity on delta wave. Extreme delta blush can occur in 30% of patients with anti-NMDA receptor encephalitis. This pattern should not be misinterpreted as seizure to increase dose of anti-epileptic drugs and worsen the awareness of autoimmune encephalitis. So it is recommended for the EEG monitoring or video electroencephalogram in difficult challenging case. Extreme delta blush is the indicative of severity and predictive of poor outcome. There are the protocol for seizure control in status epilepticus patients for first-line and second-line drug. First-line therapy recommend intravenous form of lorazepam, diazepam, and phenytoin, or midazolam intramuscular route and diazepam in rectal route. For second-line therapy, recommend using valproate and diazepam. In patients who fail for first or second-line therapy, this patient may need IV sedative medication such as pentobarbital, propofol, or midazolam. If seizures are uncontrolled, topiramate and phenobarbital can also be used. The majority of patients were treated with a combination of anti-epileptic drugs and immunotherapy, and most of the patients received multiple anti-epileptic drugs. Even ketamine is not the traditional anti-epileptic drug, but in the case report from Central report that ketamine is a useful adjunct treatment for super-refractory status epilepticus in patients with anti-NMDA receptor encephalitis. Early diagnosis and treatment of status epilepticus are associated with better neurological outcome and fewer relapse. Status epilepticus, focal seizure, and epileptiform discharge during acute encephalitis episode. This increases the risk for drug-resistant epilepsy. Ketogenic diet. It is a high-fat and low-carbohydrate diet. Increased ketone bodies. It is effective in drug-resistant epilepsy in children and adults. It is the potential option in patients with anti-NMDA receptor encephalitis. Ketogenic diet can help control seizure in patients with super-refractory status epilepticus. Immunotherapy. Patients who treat with immunotherapy can achieve seizure-free more than patients treated with only anti-epileptic drugs. So, after eliminate infectious cause, it is recommended to start the first-line immunotherapy. Anyway, it is lack of immunotherapy management guideline for autoimmune encephalitis due to no clinical trial to determine the efficacy of the treatment. So before starting immunotherapy, the intensivist should concern about the patient's comorbidities, serological status, and phase of illness. The first line immunotherapy are intravenous high-dose steroid, intravenous immunoglobulin, plasmapheresis. Second line immunotherapy is target B-cell therapy with rituximab and cyclophosphamide. Third line immunotherapy is bortezomib. The study found that the serological status may guide management, the agent selection, and prognosis of the patient. There is some complication of the first line immunotherapy. For corticosteroid, the complication of prolonged use of corticosteroid are insulin resistant, diabetes mellitus, osteopenia, increased risk for opportunistic infection. Complication of plasmapheresis are decreased arterial blood pressure, arrhythmia, paresthesia, life-threatening conditions such as shock, hypotension, persistent arrhythmia, and hemolysis. Intravenous immunoglobulin can cause higher risk for chemical meningitis, hyperviscosity, and thrombotic syndrome, and it can trigger many symptoms such as headache, rashing, chest tightness, fever, myalgia, fatigue, dyspnea, back pain, nausea, vomiting, diarrhea, tachycardia, acute renal failure, neutropenia, autoimmune hemolytic anemia. For the second line immunotherapy, rituximab. Rituximab is a monoclonal antibody against CD20. It is the second line immunotherapy for seropositive and seronegative autoimmune encephalitis with tolerability and improved outcome. But anyway, rituximab have side effects such as infusion-related reaction, infection, tiredness, and nausea. The empirical antimicrobial treatment is important too, because differentiating infection from autoimmune encephalitis may be complicated before CSF analysis. So it is recommended to early start empirical antimicrobial for CSF infection until we can exclude the infection. Dysautonomia. This is the imbalance between parasympathetic and sympathetic. It can be found in 25 to 45% of patients with autoimmune encephalitis. It is a predictor of poor response to first-line immunotherapy. Dysautonomia associated with disease progression, especially in anti-NMDA receptor encephalitis. Dysautonomia can affect cardiac function because it is the result of an imbalance between the bradycardiogenic parasympathetic and the positive chronotropic sympathetic. Cardiac autonomic discharge usually synchronized with anti-epileptogenic activity to trigger a lethal bradyarrhythmia or asystole. The brain lesions that have potentially affected the cardiac autonomy outflow are the insula, anterior cingulate cortex, and amygdala. This is the common dysautonomic manifestation: fever without infection, hypoventilation or hyperventilation, tachycardia or bradycardia, blood pressure crisis, diarrhea, hypersalivation, and erectile dysfunction. The management of dysautonomia is in autoimmune encephalitis are careful monitoring, dantrolene, external and internal cooling, pacemaker, mechanical ventilation, and hypertensive medication. Antipsychotic therapy is a drug that used to treat catatonia symptoms, with the most common presenting signs such as immobility, staring, mutism, posturing, withdrawal, and rigidity. Drugs such as lorazepam and haloperidol are the effective treatment for catatonia, but haloperidol can cause movement disorder in patients in the later stage of the disease, so use with caution. For elevated intracranial pressure problem, there are the studies that report the increased intracranial pressure in patients with anti-NMDA receptor encephalitis, and recommend the management of increased intracranial pressure are head elevation, hyperventilation with normal oxygenation, blood pressure management, hyperosmolar or hypertonic saline therapy, IV corticosteroid, and neurosurgical intervention. The need for mechanical ventilation. This is the common complication in patients with autoimmune encephalitis. The reason for mechanical ventilation are the patient have decreased level of consciousness, respiratory insufficiency, absent airway protection reflex, hypoventilation, pneumonia, sedation in psychosis or in status epilepticus. Report that 57% of patients were intubated for approximately 1 month. 68% required tracheostomy. 53% have ventilator-associated pneumonia. This is a complication of the mechanical ventilation, pneumonia, need for poor drainage, and acute respiratory distress syndrome. The factors associated with poor neurological outcome are delayed immunotherapy, longer ICU stay, need for mechanical ventilation, intrathecal inflammation, severe sepsis, medical comorbidities, and need for tracheostomy. The prognosis of the patient depends on the antibody subtype. For better prognosis for case involving cell surface antigen, worse prognosis for case associated with paraneoplastic disorder and intracellular antigen. The mortality rate of ICU admit patients range between 12 to 40%, and the main cause of death are severe pneumonia, multiple organ dysfunction syndrome, and refractory status epilepticus. In conclusion, improving autoantibodies detection and consensus clinical criteria, the incidence of autoimmune encephalitis is increased. The outcome depends on early initiation of immunotherapy. So intensivists have an essential role for multimodal treatment to optimize the outcome. Thank you for your attention.
Thank you, Dr. Pimwan. So very interesting. Your presentation is good, nice. Okay. Okay. For the next speaker, we are sorry about the Professor Das. We have a problem about the connection from him. but we can change the speaker for this session with the Dr. Kananga will present a topic about in this session.
Thank you, Dr. G. I'm sorry for the inconvenience, but Prof. Das still not join us because bad connection from India.
Okay.
So I would like to try to replace his time, and I want to talk about management of elevated ICT.
Okay, Doc.
Maybe the committee can share my presentation. Sorry, wait for a minute. Okay, I want to talk about management of elevated ICT. Slide. As we know that neurocritical care has evolved with better treatment and diagnostic modality. In neurologic intensive care unit setting, common conditions that are frequently associated with elevated intracranial pressure include acute aneurysmal high-grade FAH, severe traumatic brain injury or TBI, large intraparenchymal hemorrhage, malignant middle cerebral artery infarction with herniation, severe meningitis or encephalitis. As neurologic monitoring, ICP monitoring has been shown to be useful in the management of acute neurologic state to follow the progress of acute intracranial disease, guide intervention, and predict outcomes, especially in TBI. Like disease condition associated with increased ICP, first is intracranial space occupying methylation like subdural hematome, epidural hematome, brain tumor, cerebral abscess, intracerebral hemorrhage, and then a condition associated with increased ICP, like increased brain volume, or cytotoxic udem, like cerebral infarction, global hypoxia ischemia, Reye syndrome, acute hyponatremia, increased brain and blood volume, or vasogenic udem, hepatic encephalopathy, traumatic brain injury, meningitis, encephalitis, hypertensive encephalopathy, eclampsia, subarachnoid hemorrhage, endural sinus thrombosis, and the last condition associated with increased ICP is increased cerebrospinal fluid volume like communicating hydrocephalus, non-communicating hydrocephalus, choroid plexus papilloma. I think Prof. Das is with us here. Sorry, Prof. Das, because I think there is bad connection from India, from your place. So I try to replace your
No,
time if you
actually,
don't.
no, I am waiting in our hospital. That's why I switched off my telephone.
Oh, okay.
I'm waiting to present.
Okay, Prof. Das, I'm sorry.
Can I present now?
Yeah, okay, Prof. Das, sorry, because we think that you are in that condition. Okay, maybe I will repeat my presentation.
After your lecture, I can present. Okay?
Okay, so may I continue my presentation?
Yes, please,
sorry,
please.
sorry.
I'm waiting here. Okay.
Yeah,
Don't worry.
Thank you, Prof. Das. Okay, thank you. So this is a pathophysiology of ICP elevation. We know that Monro-Kali hypothesis is a widely accepted concept for explaining the elevation of ICP. The Monro-Kali doctrine describes the principle of homeostatic intracerebral volume regulation. The total volume of brain parenchyma, CSF, and blood is relative constant. Increase in one of the three components beyond a compensated range result in intracranial compliance system from a near linear relationship to an exponential relationship where small changes in volume result in large changes in ICP.
मेरा टेलीफोन भी ये हो रहा है.
Slide. This is intracranial compliance. We know that intracranial compliance is defined as the change in volume over the change in pressure. The relationship between pressure and volume in the brain is linear in the beginning but exponential in later phases. in later phase. As volume increase, the ICP rises slowly in point A. CSF displays into the spinal tackle sac, and blood is decompressed into the from the distensible cerebral veins. When this compensatory and compliant redistribution mechanism no longer continue, ICP can increase much more rapidly with just small increments of additional volume. The amplitude of the ICP pulse wave might provide a clue that compliance is reduced. As compliance falls, the ICP pulse amplitude increases, point B. During the high ICP crisis, ICP waveforms may show that the second peak may rise as high as the first peak or even higher. Slide. And what we know about cerebral perfusion pressure. The main negative consequences of elevated ICP is reduced cerebral blood flow and secondary hypoxic ischemic injury due to poor flow. Cerebral perfusion pressure is calculated as MIP minus ICP. CPP along with cerebral blood volume determines cerebral blood flow. Normally, autoregulation of the cerebral vasculature maintains cerebral blood flow at constant level between a CPP of approximately 15 until 100 millimeter mercury. As we know that brain injury leading to impaired cerebral autoregulation might cause cerebral blood flow to approximate a more straight line relationship with CPP. And right now, CPP optimization should be greater more than 60 millimeter mercury to avoid ischemia and below 110 millimeter mercury to avoid breakthrough hyperperfusion and cerebral edema. And just reminding about pathological pressure waves. In patients with raised ICP, pathologic ICP waveform may occur. We know about Lambert A waves or plateau waves represent prolonged periods of profoundly high ICP. And Lambert B waves are a shorter duration, lower amplitude elevation in ICP that indicate that intracranial compliance reserves are simply compromised. Lambert A plateau waves is considered as a high risk of further or ongoing brain injury, with critically reduced perfusion as a result of prolonged period of high ICP crisis. It often occurs abruptly when either CPP or intracranial compliance is low. The duration might vary from minutes to hours, and pressures as high as 50 to 100 millimeter mercury may be seen and considered ominous in the setting of acute brain injury. The important thing in this pathologic pressure wave is not to memorize which is Lambert A or Lambert B per se, but to understand that trend of ICP elevation and figure out the overall picture as to why there is intracranial hypertension and how brain compliance is coping with the injury. Accurate assessment of the underlying etiology will help guide the clinician to choose the right type and method of treatment. Slide. This is causal relationship between primary brain injury, intracranial hypertension, and secondary brain injury. We know that in primary brain injury cannot be reversed, and secondary brain injury is defined as any physiological event that can occur within minutes, hours, or days after the initial injury and lead to further damage of nervous tissue. It can be detected through clinical examination and intracranial pressure monitoring. And it's mostly due to increased ICP and confirmed by imaging tests. Slide. This is my clinical manifestation of intracranial hypertension like headache, nausea and vomiting, diplopia, decreased level of consciousness, papil udem. Papil udem is reliable sign but may develop after several days of increased ICP. And then papillary dilatation, downward deviation of the eyes, and the last sign is casting triad, severe hypertension, bradycardia, and irregular respiration. This is an ominous sign of brainstem compression or brain herniation. What is our indication for ICP monitoring? Our indication for ICP monitoring is when this patient with GCS score 3 until 8 after resuscitation with abnormal admission of head CT scan like there is hematome in head CT scan interpretation. There's contusion, ödem, herniation, and compress of basal system. And patient with GCS score 3 until 5 and until 8 after resuscitation, with normal admission of head CT scan plus 2 or more of the following: age more than 40 years, motor posturing, and systolic blood pressure less than 90 millimeter mercury. Slide. What is our goal? Intracranial pressure treatment method is to maintain ICP at less than 20 to 25 millimeter mercury, and to maintain CPP or cerebral perfusion pressure at greater than 60 millimeter mercury by maintaining adequate mean arterial pressure, and to avoid factors that aggravate or precipitate elevated ICP. And what do we know about ICP monitoring? The current recommended gold standard technique to measure ICP is invasive. However, it is important to visit other modalities which can be broadly classified into non-invasive and invasive methods. But we know that invasive method is less dangerous and high risk of infection. Slide. This is an invasive method of ICP monitoring, like external ventricular drainage, lumbar puncture, epidural and subdural device, and intraparenchymal device or fiber optic or stent gas. There is disadvantages of invasive method of ICP monitoring, and mostly is high infection rate. Slide. And this is a non-invasive ICP monitoring method who will right now become most frequent to use, like brain CT, because fastest and most effective, most cost-effective method. Brain MRI become more accurate assessment of soft tissue and cerebral substance lesion. And then TCD, transcranial Doppler ultrasonography, with a patient in bedside, but highly operator dependent. And ONSD, optic nerve sheath diameter. ONSD is right now become more popular because cheap, efficient, and not time consuming. And tympanic membrane displacement on, but it's less, it's like inaccurate and unreliable. Slide. What is our management of rise ICP? Our management of rise ICP focus on 4 main axes. First, to control and manipulation of vasoreactivity, cerebral blood flow and flow metabolism coupling, managing the blood or brain osmotic gradient, reducing the metabolic rate of oxygen consumption of cerebral tissue, physical or surgical modality with affect intracranial compliance. This is staircase therapeutic approach of intracranial hypertension. We know that an optimal therapeutic strategy is considered the step-by-step escalation of available intervention. Then and this is specific for each patient. We can generalize. And the primary goal is to maintain ICP below 22 millimeter mercury and CPP above 60 millimeter mercury. Initially, general prophylactic measures should be applied immediately to all patients with suspected intracranial hypertension. Based on specific indication and condition, surgical resection of MES lesion and CSF drainage should be considered as an initial treatment for lowering ICP. The following step is in turn include hyperosmolar therapy, hyperventilation, therapeutic hyperthermia, and then to control elevated ICP, refractory, we know about refractory intracranial hypertension or RIT, high dose barbiturate administration, and then the compression craniotomy. At last steps are recommended. This staircase therapeutic approach is based mainly on clinical experience rather than on strong published evidence. So when we talk about barbiturate coma, there's still a lot of evidence because I think there is no RCT to describe more about the effectiveness of barbiturate coma. Okay, next slide, please. So we talk about general prophylactic measures in this step case in the next slide. We know that intubation and mechanical ventilation should be applied in comatose patients. We have a guideline that a patient with disease less than 8 should be intubation and ventilate. Mechanical ventilation its aim is to avoiding hypoxemia, hypercapnia, and hypocapnia. So we should maintain PaCO2 values between 35 and 40 millimeter mercury. And why? And can we use PIP during mechanical ventilation with patient with acute brain injury? Because with PIP, there is a risk of ICP elevation and reduction of CPP due to increased intrathoracic pressure and decreased cerebral venous drainage from the superior vena cava. And in this clinical trial from journal that I read, that this effect to risk to high to elevate the ICP and to reduce the CPP is when we apply PIP more than 15 centimeter SO2 in patient who is in hypovolemic condition. Slide. And how about blood pressure during the general measure to optimize the patient with elevated ICP? We know that hypotension should be avoided because it is an independent risk factor for poor outcome in patients with acute brain injury. We know that patients with impaired autoregulation and hypotension leads to cerebral ischemia due to CPP reduction. And so we should remember that patient with systolic blood pressure less than 110 millimeter mercury, we should call that this patient with hypotensive. BTF guideline suggests that patient more than 50 until 69 years old should we maintain the systolic blood pressure more than or minimum 100 millimeter mercury. And for patient with range between 15 and 49 years old, is to we should maintain the systolic blood pressure is more than 110 millimeter mercury. And when the MEP is more than 110 millimeter mercury and ICP more than 20 millimeter mercury, we should make lower the systemic blood pressure in order to decrease cerebral perfusion significantly. And we suggest to use short-acting citrable agents like labetalol and cardipine. And according to the lab's guidelines for CBI, the recommended target CPP value is between 60 and 70 millimeter mercury, as it has been associated with improved survival and favorable outcomes. We should remember that in patients with traumatic brain injury or with elevated ICP, the head of the bed should be elevated to 30 degrees. The patient has fresh midline so that the internal jugular vein is not compressed and cerebral venous drainage is facilitated. Head elevation may reduce ICP without adversely affecting either CBF or CPP. And how about temperature control? We know that Prof. Siti already talked about fever and hypothermia in neurointensive. But how about the temperature control? We know that elevated temperature affect ICP by increased cerebral metabolic demands and cerebral blood flow. It has been shown that patients with ICF who develop a body temperature more than 37.5 degrees Celsius within the first 72 hours have significantly worse outcomes determined by Glasgow Outcome Scale 1 or 2. And due to the harmful effect of increased temperature on the cerebral parenchyma, it is recommended that it should not exceed more than 37 degrees Celsius. Slide. And how about glycemic control? Hyperglycemia is associated with increased mortality in patients with acute brain injury. So we said that with if blood glucose is more than or minimum 150 milligram per deciliter, we should initiation of insulin therapy. For most patients who admitted to an ICU with diagnosis of ischemic stroke, intraparenchymal hemorrhage, ACH or TBI, titrate to achieve blood glucose value absolutely less than 180 milligram per deciliter. So if the patient in Neuro ICU with blood glucose less than 100 milligram per deciliter, we should stop when we use infusion of insulin. Slide. And how about seizure prophylaxis? BTS guidelines do not recommend the prophylactic use of phenytoin or valproate for preventing light of post-traumatic seizure. Phenytoin is recommended to decrease the incidence of early post-traumatic seizure within 7 days of injury, when the overall benefit is felt to outweigh the complication associated with such treatment. So prophylaxis, anti-epileptic therapy in other acute neurological conditions is spontaneous ischemic or ischemic stroke is not recommended. Right? And how about acute intervention? Acute intervention include hyperventilation. What we know about hyperventilation? Hyperventilation is an effective and rapid method of treating intracranial hypertension. We know that reduction in PCO2 induces vasoconstriction of cerebral arterioles and a decrease in cerebral blood flow, resulting in ICP reduction. But we know also that prolonged aggressive hyperventilation might lead to a critical decrease in local cerebral perfusion and cerebral ischemia, potentially resulting in worsening of neurologic injury, particularly in the first 24 hours until 48 hours. So we know that hyperventilation might have a role as temporizing measure for the reduction in elevated ICP, but we know that we should not to continue abruptly, and we should taper slowly over 4 until 6 hours to avoid vasodilatation of cerebral arterioles and rebound increase in ICP. Right? And how about hyperosmolar therapy? Right now we know about mannitol and hypertonic saline. So we know that osmotic agents reduce brain tissue volume by drawing the water out of brain tissue and into the systemic circulation, and then excreted by the kidney. But we know that hyperosmolar therapy requires an intact blood-brain barrier, and we know that in traumatic patient and traumatic head injury patient, there is leakage in blood-brain barrier. So this is make the molecule between blood and interstitial. There is an equilibration of molecule between blood and interstitial fluid of the brain. So the osmotic agent exert their effect largely by removing water from the remaining normal brain tissue. And we know that the effective dose of mannitol, usually we use mannitol 20%, is 0.25 to 1 gram per kilogram body weight every 6 hours. And we know that those less than and those more less than 0.5 gram per kilo are usually considered less effective. And we should remember that when we use mannitol, we should maintain the serum osmolality between 310 and 320 milliosmol per liter. Right? And we know right now is hypertonic saline. Hypertonic saline is used alternatively to mannitol. So compared to mannitol, it has a higher reflection coefficient. So therefore, we say that hypertonic saline is less able to cross the blood-brain barrier and may have a stronger osmotic action. Thus, it reduces ICP by decrease cerebral edema, while at the same time increase cerebral perfusion pressure by improving MAP. Slide. And how about sedation and analgesia? I think the journal say that sedation and analgesia are an integral part of medical treatment of intracranial hypertension. We know that when patient on ventilator is dysynchrony, and become agitated, there is increase in intrathoracic pressure and make the thoracic venous rhythm become decreased, and with increased cerebral blood volume and thus ICP. So this is what is the drug to can we choose to do sedation and analgesia? In this journal, say that propofol is preferred drug compared to midazolam or benzodiazepine because it's rapid onset. Back to the slide before. Because propofol is preferred drug for sedation because it's rapid onset and offset. But we know when we use propofol in high dose, it become there is a risk to become propofol-induced syndrome. But propofol have a benefit to increase seizure threshold and better quality of sedation when compared to midazolam. And how about barbiturat? We know that barbiturat have more benefit effect than propofol to decrease the ICP, because barbiturat has effect to suppress brain metabolism, reduce CBF, and improve oxygenation of the cerebral tissue with its inverse pill or Robin Hood phenomenon. And we know that, from BTF guideline, we know that high dose barbiturat administration is only to control elevated ICP refractory to maximum standard medical and surgical treatment. So if the ICP is not a sign of refractory high or intracranial elevation, we should not choose barbiturat as first line. But if the patient with refractory high intracranial hypertension, we should choose barbiturat. And remember that when we choose barbiturat, we should make sure that hemodynamic is stable before and during the therapy. Slide. And how about therapeutic hypothermia in acute intervention for patients with elevated ICP? We know that hypothermia decreases cerebral metabolism and may reduce CBF and ICP. However, to date literature, data are inadequate to support this neuroprotective effects. And we know that, should know that favorable neurologic outcome with therapeutic hypothermia is reduced mortality using therapeutic hypothermia have only been demonstrated after ventricular fibrillation and ventricular tachycardia cardiac arrest. And there was no differences in neurological outcome or survival at a target temperature of 33 degrees Celsius versus 36 degrees Celsius. So this benefit of therapeutic hypothermia remains more high quality of RCT in this population. And we know that serious adverse effects are associated with hypothermia, especially if used for a prolonged period of time. It's like hypokalemia, atrial and ventricular arrhythmia, hypotension, coagulopathy, and risk of infection, particularly ventilator-associated and nosocomial pneumonia, is elevated. And we know that corticosteroid is only indicated for reducing ICP in abscess or neoplasm associated with vasogenic ödem. Slide. This is a resection of macellation. Based on specific indication and condition, resection of macellation might immediately lower ICP. But we should remember that supratentorial hematome evacuation in deteriorating patient might be considered as a life-saving measure. Slide. And how about decompressive craniotomy? Decompressive craniotomy, which consists in creating a large bone window, provides a large reserve to the swollen brain, negating the Monro-Kelly doctrine of fixed intracranial volume. In this way, the decompressive craniotomy alone lowers ICP by 15% and with dural opening by 70%. But the main indication for the compressive craniotomy is massive hemispheric ischemic stroke. And regarding TBI, the recent BTF guideline do not recommend the frontal decompressive craniotomy to improve outcome. Although this procedure has been demonstrated to reduce ICP and to minimize days in the ICU. And this is a cerebrovulnar fluid drainage. As I said before, that this is a risk of when the operator placement of ECD, there is a major risk in infection, especially ventriculitis and meningitis and hemorrhage. This is a new option for patients with raised ICP and still under investigation, and they have no place yet in clinical practice, like hyperbaric oxygen therapy. The use of hyperbaric oxygen therapy in TBI has been shown to reduce ICP, may reduce the risk of death and improve GCS, but there is little evidence that survivors have a good outcome. Therefore, its application to this patient cannot be supported. And there is research about progesterone. But still, progesterone has been shown to have potentially protective properties since it might slow the development of malignant cerebral edema and ICP elevation, but still need further research. And how about ketamine? Ketamine has been previously reported to cause an increase in ICP. But current literature support that it does not increase ICP in severe TBI patients that are sedated and ventilated, and in fact may lower it in selected case. So I come to summary of my presentation. So the management of rise ICP focus on control and manipulation of vasoreactivity, CBF, and flow metabolism coupling, managing the blood and brain osmotic gradient, reducing the metabolic rate of oxygen consumption of cerebral tissue, physical and surgical modalities which affect intracranial compliance. The primary goal is to maintain ICP below 22 mmHg and CPP above 60 mmHg. And general prophylactic measure as initial treatment for lowering ICP initially will be applied immediately to all patients with suspected intracranial hypertension or elevated ICP. Surgical resection of methylation and CSF drainage will be considered. The following steps include hyperosmolar therapy. We have mannitol and hypertonic saline, hyperventilation, and therapeutic hypothermia. And to control elevated ICP refractory, after maximum standard medical and surgical treatment, at first is high dose of barbiturate administration, and then the compressive craniotomy as last step are recommended. Thank you. I give back to Dr. I give it back to Dr. Dwi. Thank you very much.
Thank you, Dr. Kenanga. It's very applicative for your presentation. Thank you. And the last presentation, we would like to invite Prof. Das. He is from India. His presentation, the topic is treatment of infectious meningitis and encephalitis in the neurocritical ICU, critical care unit. Just a little curriculum vitae from Professor Hari Haradas. He is the Emeritus Professor Anesthesiology and Pain Medicine at the Fortis Memorial Research Institute, Guardian. And furthermore, Professor Das with presentation. Professor Das, the stage is yours, please. Thank you. Professor Das, can you hear? We can connect the Professor Das again, please.
Excuse me, Dr. Dwi. I think maybe we can finish our discussion, and then Dr. Das will continue in the next session. If Dr. Das, Prof. Das will have a bad connection.
Okay. Okay, Dr. Kenanga. For this session, finally, the next session is a discussion in our topic. Yeah, the colleges who want to ask the relation to topic, you can write them in the box of Q&A. Some of question has been collected in here. Some question I will read the questions to Professor Quek. Professor Quek, sorry, I can hear.
Yes, I'm here.
To Dr. Quek, Professor Quek, yeah. There's the question. It is allowable using the, sorry, I read this. Professor Quek, the question from Dr. Dani. Is it allowable using the PIP intraoperative in ICH patient without any lung disease? And how high PIP that can be used?
Yeah, thank you very much for that question. I think it's a very good question. So in my practice, even for any form of surgery, if there's no contraindication, I would usually use PEEP routinely. In patients with no lung disease, I would usually just use a fairly low PEEP of around 5. There's often no need for more if they have no lung disease. Now, often in a patient who has intracerebral hemorrhage or maybe even traumatic brain injury, during anesthesia, I would also routinely use a PEEP of around 5. So in the absence of any lung disease, there's rarely any need to use high PEEP. So I would not advise using high PEEP when there's no indication for high PEEP. But certainly in someone without lung condition, I think just using a fairly low PEEP of no more than 10, even in the presence of any brain injury, should be okay. And besides, during surgery, you can always look at the condition of the brain and see whether there's any resultant congestion if you were to increase the PEEP slightly. Thank you.
Okay. The other questions in RDS patient with AB, which is a better pressure or volume control? Which is better, pressure control or volume control? It's mean.
Yeah, thank you for that question. So my personal preference is I usually use pressure control.
Okay.
And usually for the machines that we have these days, they often come with pressure regulated volume control. So in a sense, you can do pressure control mode, but still with some degree of volume control. So in a sense, it allows you to kind of merge the two modes. So actually, that's my default preference these days for the machines that have PRVC. I'll use that. If not, I often will use volume control rather than pressure alone. Because I think pressure alone, you have to be really quite careful with the volume. Sometimes you might change or drop quite a bit depending on any changes in compliance that it might be. Thank you.
Okay, thank you, Dr. Prof. Kwek. The other question from Dr. Buyung. How long is the tolerance of a form mild hypnocapnia maneuver for cases of increased intracranial pressure, Prof? How long tolerance?
Yeah, I think generally speaking, I would not advise any form of hypocapnia. Sorry. I would generally aim for normal capnia in most patients. And normal capnia meaning an arterial CO2 level of 35 to 44. So that would be my default. In fact, often I'll just keep it between 35 to 40. And I think most patients, you should be on that. If there's a desire to achieve a bit of hypocapnia for ICP control, I think as a tier 1 measure, if the need arises, then one could consider hypocapnia down to no less than 30 millimeters mercury on the arterial blood gas. I would not go lower than that, and in my practice, I no longer aim for anything lower than 30 because I think that's potentially quite harmful. And as I showed in my presentation, I think there is no longer a recommendation for that long term. I think if you do acutely hyperventilate to control a brain that is herniating, then try and reverse that to normal capnia as soon as that is possible later on. If you persist in hyperventilation for a period of time, we're told that in about 6 to 8 hours, actually the brain will readapt fully to that new level. So whatever initial benefit you might have had from that mild hyperventilation will usually be lost after about 6 hours. So I think generally speaking, it is something more for an acute setting and best avoided if it's not necessary. Thank you.
Okay, Prof. Kwek, thank you. There's other one question for yours from Dr. Marioni Kalimantan Tengah, Prof. When and what cases should be done blood gas analyzer examination at the time of the anesthesia will do? what and when the
Yeah,
cases.
I think generally one
Blood
needs to
case.
do, as I suppose as in our practice today, most of us would monitor an end tidal CO2. And so an end tidal CO2 is real time and it's generally quite reliable. I think what is needed initially is a calibration of what the arterial and end tidal carbon dioxide difference is. So most patients under anesthesia, if you have no lung disease, the gap is usually between 5 to 10. Patients with more lung disease, that gap widens. So I think quite useful sometimes to do a blood gas in patients for whom control of the brain compliance is important intra-op. Then you can do a blood gas just to have an idea what the gap is in that patient. And then knowing the gap, you can pretty much estimate what the arterial CO2 is, and then you can follow that for the rest of the op. There's probably no real need to do that repeatedly. Thanks.
Okay, Prof. Quick, thank you. And the CO2 is very important, but in Indonesia is very expensive things, I think. No, so many, is not all hospital in Indonesia have anti CO2, sorry. And this is the end of our session. And thank you for Prof. Kwek, Dr. Iwan, Dr. Pitwan, Dr. Kenanga. I hope we can take some message from the speaker. I hope we can take this presentation for our practice. Thank you for all. We can see the next session. Thank you, Prof. Thank you, Dr. Pimwan, Dr. Iwan. Thank you, Dr. Kenanga. See you.
Thank you.
Thank you very much. Thank you.
Thank you very much.
Thank you.
Dr. Kenanga, please.
Yeah. Thank you, Dr. Dwi. Okay, sorry. Thank you so much.
Thank you, speakers and moderators, for the second session of plenary lectures.
For the third session, we will introduce those who act as speakers and moderators. We have 3 speakers: Professor Das from India,
Dr. Tu Tianming from Singapore.
Professor Masahiko Kawaguchi from Japan.
For the moderator, Dr. Dewi Yulianti Bisri, Neuro Anesthesiologist Consultant, Obstetri Anesthesiologist Consultant, allow us to read a little CV about her.
She was graduated from Medical Faculty of General Ahmad Yani University. Then she continued her studies as anesthesiologist at Pajajaran University and advanced her studies as neuro anesthesiologist consultant, obstetric anesthesiologist consultant, and doctoral degree at Pajajaran University.
Now, she served as the head of subspecialist study program for neuroanesthesiology consultant at the University of Pajajaran. We welcome you, speakers and moderator.
Please, Dr. Dewi, the time is yours.
Okay, thank you so much for introducing me to everyone. So, Assalamualaikum warahmatullahi wabarakatuh, and good afternoon, everyone. Welcome to this symposium to all speakers and participants. If participants have any question, you can writing on the Q&A room. So today we have topic about the traumatic brain injury. We have 3 speakers in here, and the first speaker is Professor Hari Hardas. Second speaker is Dr. Tu Tianming, and third speaker is Professor Masahiko Kawaguchi. So we will start with the first. Our speaker is Professor Hari Hardas from India. Maybe you can show me about the CV. Okay, Professor Harry Hardas is Emeritus Professor Anesthesiology and Pain Medicine. So we had 20 minutes for presentation, Professor Harry Hardas. So now the time is yours. His topic is about, oh, sorry. Okay, the time is yours now. Please, Professor Das. Professor Das, you still mute your microphone. Can you open it?
Sorry. Hello.
Okay, now we can hear you. So please.
Thank Dr. Dewey, who is like my daughter. Can I have my first slide, please?
Okay. Can you?
Because I on the slides from here.
Okay, we will try to helping you to show or to share the slide.
In these difficult times, I invoke the Almighty God to keep our Indonesian friends blessed and safe. I have greetings from the hospital, and today's topic is a very infective topic. Infection of the meninges and brain is an acute neurological emergency. Early diagnosis and prompt management helps in achieving good neurological outcome and decreasing morbidity and mortality. Next slide. Next slide, please. I will cover my lecture as per the definition, etiology, clinical presentation of meningitis and encephalitis. How can we diagnose these patients? And what is the ideal management? And what are the preventive measures we can take so that such dreaded disease does not occur again? Next slide. Meningitis, as you know, it is the infection of the arachnoid or the meninges and the subarachnoid space. And whenever there is involvement of the brain parenchyma or infection of the brain parenchyma, then it is called encephalitis. And whenever both are involved with infection, then it is called meningoencephalitis. And this infection may turn into abscess or focal infection of the brain. Next slide. The etiological factors of meningitis are mostly the bacteria, fungal, parasitic, or maybe mycobacteria, that is chronic tubercular and other causes. And another important cause is viral. But amongst the bacterial, it is the streptococcal pneumoniae, which is very common, followed by Neisseria meningitidis, Haemophilus influenzae, and Listeria monocytogenes is very commonly seen in pregnant patients causing meningitis. Of course, the secondary systemic mycosis, that is Cryptococcus and coccidioidosis and histoplasma, they cause the fungal meningitis, and Candida infection usually a hospital-acquired fungal infection. Parasitic like cysticercosis, that is Echinococcus granulus, Echinococcus infection, which give rise to tapeworm infection, and it may lead to meningitis. Amoebic meningitis is also another parasitic infestation, which is very dreaded. And as you know, tubercular is a chronic disease, and it may lead to tubercular meningitis and encephalitis. Other causes of meningitis are chemicals, drugs, cancer, following radiotherapy, sarcoidosis, and trauma if there is basal skull fracture following surgery, particularly pituitary surgery, CSF leak, then there is infection of the meninges. Next slide. This is a dreaded disease that is called brain-eating amoeba, that is Naegleria floweri. It produces necrosis of the brain by eating the neuronal cells, and it is a very critical condition. Next slide. The encephalitis is mostly caused by viral infection, and enterovirus is the commonest, and it is very predominant in USA, and it can give rise to 80% of the cases aseptic meningitis. Herpes simplex is also another cause of meningitis, herpes zoster, and the less common causes include mumps, HIV infection, cytomegalovirus, and varicella zoster. The infection with CMV, Epstein-Barr, and HIV, they also can give rise to viral meningitis. Next slide. Because we live in the tropical countries like your country, and in tropical countries, certain specific, because of the seasonal changes, you may find encephalitis and meningitis syndromes, particularly Japanese virus, Japanese encephalitis, which is spread by mosquito-borne flavivirus, and the Aedes aegypti spread dengue, and that may also lead to dengue, meningitis, and encephalitis. Chikungunya, which is very commonly seen in Kerala of southern part of India, also can lead to meningitis. And nowadays, Zika virus has also emerged. That is again, Aedes mosquitoes spreads this. It may also give rise to meningitis and encephalitis. So one has to take care of all these mosquitoes. That is the best preventive measure one can adopt. Next slide. And some of the monocytogenes, rickettsia, brucella, all these things also can lead to meningitis and encephalitis. One must remember these things also in mind. Next slide. Some of the meningitis you can distinguish or diagnose quite early, seeing the clinical manifestation. But it is usually the hematogenous spread, and at times it is the extension of the infection, that is from the bone or sinuses. Foreign body like ventriculoperitoneal shunt, there is retrograde infection spread into the brain from the abdominal cavity. And in the immunocompromised patients, like patients with severe diabetes or uncontrolled diabetes, or who had undergone asplenia, or spleen has been removed, HIV patients, patients on steroid, and patients on immunosuppressants, radiotherapy and chemotherapy, they are vulnerable to meningitis and encephalitis. Of course, other risk factors are extremes of age. Extremes of age means both young and old age, crowding, overcrowding, contiguous infestation. Nowadays, keep a distance because of the COVID. Same thing also applicable here. Recent neurosurgery, head trauma, endocarditis, and particularly drug abusers. They are also is a major vulnerable group. Next slide. The pathophysiology of neural damage usually occurs through the bloodstream. The green bacteria, they cross the bloodstream and they are tried to be engulfed by the neutrophils. But when they overwhelm the neutrophils, then it affects the neuronal cells by releasing cytokines and chemokines, and thereby it destroys the neuronal cells and give rise to meningitis and encephalitis. Next slide. The clinical presentation and the triad, that is fever, headache, and neck stiffness, occurs more than 50 to 60% of the patients. But there may be altered mental status, which occurs in 95% of the patients. If two symptoms are there, then one should suspect meningitis. There is no definitive symptoms or signs that rule out meningitis or encephalitis. The patient may be having prodromal symptoms that I'll be discussing. Next slide. And coming over to the signs, Kerning signs, neck rigidity, and Brzezinski signs, one can elicit to diagnose clinically meningitis. Some of the meningitis, they have classical signs and symptoms like a petechial hemorrhage, purpural rash you'll find in meningococcal meningitis, labyrinthitis giving rise to reeling of head, and difficulty in maintaining balance in Haemophilus influenzae. Cough, weight loss, cranial nerve deficit will occur in tubercular meningitis. A prodrome of fever, myalgia, headache is there with viral meningitis and encephalitis. Herpetic rashes commonly seen in herpetic meningitis, and there may be diplopia, dysarthria, ataxia in immunocompromised or HIV infected patients. Next slide. One can distinguish meningitis and encephalitis with the basic fundamental rule, that is, if there is normal brain involvement, because the patient may be stuporous or they are frequently throwing convulsions, then one may distinguish it may be encephalitis, whereas in meningitis there is high fever, neck rigidity, and other things. Next slide. The gold standard of diagnostic therapy, is CSF analysis. That is, you must assess the pressure, cytology, biochemistry, that is blood glucose, CSF glucose and proteins, gram stain, then culture and sensitivity. CSF lactate also nowadays is being in higher centers, and polymerase chain reactions also helps in diagnosing tubercular and viral meningitis. CN imaging, that is CT scan and MRI scan, is not the gold standard, but at times they are required to distinguish or to diagnose meningitis and encephalitis. Role of EEG is very controversial. If the patient is having or throwing convulsions or to rule out focal or generalized, then one may resort to EEG. Next slide. Of course, everybody knows how to do lumbar puncture. It is done in lateral position. And you always, before lumbar puncture, you must keep 4 vials ready for collection of samples. And then once you are in the subarachnoid space, slowly remove the stellate and measure the pressure by connecting into the pressure monitoring monitor, and you measure the pressure, because in infective meningitis the pressure is very high, and you'll have to be, if the pressure is very high, then you must remove it very slowly. And of course, for protein and glucose, I have told you that those things you must collect. Next slide. And this is the distinguishing feature which one must remember, particularly the students. The normal CSF opening pressure is around 25 to 20, whereas it is increased in bacterial meningitis several folds. However, in viral meningitis, tubercular meningitis, and fungal meningitis may be increased, but in viral and tubercular, it may be normal. Cell count is maximum more than 1,000 per cubic millimeter in bacterial, and in viral maybe less than 1,000, and in tubercular it is around 100 to 500, and same thing also is seen in fungal meningitis. Neutrophils predominate in the bacterial meningitis, however lymphocytes are there in viral, tubercular, and fungal. Glucose is, as you know, 2/3 of the serum glucose, and it should remain less than around 40. In bacterial meningitis, because the infective organisms, they consume the glucose, that's why it is very low. However, in viral meningitis, it remains normal, and in tubercular and fungal, it also remains low. CSF protein is around 45 milligram per deciliter, and it remains usually highly elevated in the bacterial meningitis because they release proteins. And it remains normal and elevated, slightly elevated in viral meningitis, and in tubercular, it also remains elevated, and in fungal, it is also increased. Next slide. Polymer chain reaction, that is rapid detection of causative pathogens whenever the confusion occurs. If you cannot diagnose from the CSF and the CT and MRI, then one must go for this assay, and it is 100% sensitive and 98.5% specific. It may be used to detect the bacterial DNA, and in viral meningitis, CSF adenosine deaminase is measured through this assay. Mycobacterium tuberculosis is is diagnosed through PCR, and nucleic acid amplification is also can be carried out to diagnose tubercular meningitis. Next slide. This is a paper published very recently, and they have shown that CSF lactate level, there is increase, fourfold increase in the acute viral meningitis, in bacterial meningitis in comparison to the viral meningitis and control groups. CSF lactate presented higher specificity, that is 92%, and negative predictive value is 94% compared to glucose and other things. Next slide. The other biomarkers are being carried out in the advanced centers to diagnose the cryptococcal, the difficult meningitis, such as cryptococcal lateral flow assay, genes expert, and other things which are very sophisticated, and it is being carried out in the advanced centers of the world. Next slide. The guideline to carry out CT and MRI, different guidelines have been given by the American Infectious Disease, European, and the Swedish group. Next slide. But whenever there is head trauma or the patient is immunocompromised, there is no neoplasm, there is focal and you suspect papilledema or raised intestinal pressure, or there is depressed level of consciousness, then one must order for CT scans. Difficult in being lumbar puncture also, that is also another indication. The left-hand side slide, the CT scan of one of our patients, you will find the patchy meningitis in the temporoparietal region, and there is necrotic brain tissue you can see with distension of the frontal horns. But in the right side, there is ventriculitis, and there is abscess formation on the left side of the brain, and which was later on drained by placing an EVD and continuous drainage. Next slide. And the patient recovered after 3 months. Coming up to the emergency management, the patient will come to the emergency ward, in which you will have to do a triage. And ABC of resuscitation, one should apply immediately if there is difficulty in breathing, particularly these patients, because of the high fever. There may be tachypnea or hyperventilation. These patients may be obtunded or decreased cough reflex and gag reflex. Then you may have to secure the airway, institute breathing, and take care of the heart rate and blood pressure, assess the GCS, estimate the blood glucose, and simultaneously, if possible, serum sodium to rule out hyponatremia and hypernatremia, and take blood samples and start IV and resuscitate, take care of the blood pressure. Coagulation profile and blood culture must be sent simultaneously. Next slide, please. Urinary catheter may be placed. Resuscitate these patients on sepsis guideline, that is 15 to 20 ml fluid. One can administer rinolactate or normal saline per hour, and treat the seizures with midazolam and other things. Anti-edema measures if needed, and empiric antibiotic treatment. Next slide. Coming over to the empiric antibiotic treatment, usually ceftriaxone, vancomycin, ampicillin, and ceftazidime are used. And of course, this is the slide which shows the dose to be administered and continued for 5 to 7 days in empirical. Next slide. Once the culture comes positive, then you must start the appropriate antibiotic. Coming over to the steroid, steroid is a very controversial. The neurologists, they prefer steroid, neurosurgeons, they don't, because I will be sharing with you one patient where we did not use steroid. I argued with the neurosurgeons, but they told no. But steroid is used to prevent the cytokines stir and responsible for most complication of the meningitis and seizures, hearing loss. These are minimized, and particularly if the patient has got venous infarcts and raised ICP, steroid may be useful. But our neurosurgeons, they don't believe in steroids. Next slide, please. The antibiotic treatment should be continued for 7 to 14 days. If no organism found despite clinical and CSF has to be done every 48 hours for the cells and glucose, and empiric to be and then for the LP, I have told you, and particularly meningoencephalitis, this antibiotic treatment has to be continued for 21 days. And patients should be monitored clinically for any complications, particularly the hydrocephalus, stroke, that is, of course, well known. Next slide. Long-term complications are sensorineural hearing loss. Convulsions may occur frequently. There may be memory difficulty, learning disability, gait imbalance or gait problems, arthritis and deformities. And in these deformities, the anesthetist may also play a dominant role by giving blocks so that the deformities are corrected. And of course, brain damage, kidney problems, these patients may have. Next slide. This is a case report I want to share because in these difficult times, 2 years, the Chinese virus has created havoc, that is coronavirus. And this is a case report published in New England Journal of Medicine from Japan, where the, next slide please, the meningitis and encephalitis was diagnosed through CSF. The, the COVID test was negative, but the CSF showed viral markers, which was positive, and this case was treated effectively. And this was, of course, Japanese group. First publication. Next slide, please. And this is a meta-analysis where they have done, they followed 61 patients, 25 studies, 54 patients of them had completed investigation. CSF showed high protein and lymphocyte pleocytosis. There was focal epileptiform discharge and slowing in the background. A myriad of radiological abnormalities they have documented. Temporal lobe hyperintensity and diffusion restriction was noted in the MRI. Next slide, please. This I will be sharing with you one of our patients which we have recently treated, and he is still there in the hospital since last 1.5 months. A 27-year-old male with severe head injury with basal skull fracture and fracture humerus, for which he was operated on 15th November. Then he was discharged. Then after 4 or 5 days, he came to us with CSF discharge from the nose. And the patient was posted for surgery, but he developed high-grade fever for which the surgery was deferred. And then fever was better with antibiotic treatment. Then the patient was posted for transnasal endoscopic CSF repair, and it was carried out. Postoperatively, patient developed after 2 days high-grade fever with grand mal seizures. Patient was intubated, managed with midazolam drip, and Umaya reservoir was placed on 29th, and the CSF was sent for routine and culture, and CSF showed severe bacterial meningitis. And the CSF was carried out alternate days to find out the glucose level, proteins, and the neutrophils. Next slide. This is the patient where you can see on the right side the EVD, the CSF is being drained out from the ventricle, and the patient is on ventilator. Of course, tracheostomy was done 5 days after intubation. Next slide. This is the MRI scan. You can see on the right side, there is pneumocephalus along with the infective lesion, for which the patient was having convulsions. Next slide. And the patient was tracheotomized after 5 days, and now he was, after 7 days, he was weaned up from the ventilator on TP's trial. But the CSF, you can see, CSF is drained out, and you can appreciate the color of the CSF. Next slide. See, this is the CSF analysis. You can see appearance is hazy on 24th, which continued till 7th January. The proteins were very high, which was till 7th January, 215. Of course, on 24th, it was 45. Glucose was normal, slightly higher on the 24th December, which was less than 2 on 29th, and it slowly increased to 4 on 7th. So it takes such a protracted days. Total count was 68 on the 24th. It increased to high level, very high level, that is on the 3rd, and now I'm on 7th, it was 2,190. Microorganisms, there was occasional gram negative on the 7th, which was Acinetobacter on the 3rd. Now the patient is taking orally and is in the ward after staying in the ICU for more than 40 days. Next slide. Now this is the patient at the, before the discharge. Next slide. So coming over to the prevention, as you know, prevention is the best policy nowadays in this during the corona times. So how to prevent this meningitis and encephalitis appearing, that is coughing, sneezing, kissing, sharing utensils, toothbrush and cigarettes are absolutely contraindicated. Whenever you are coughing and sneezing, put your handkerchief on your nose and mouth. Wash your hands regularly. Practice good hygiene. This has taught us recently. Stay healthy by healthy food, exercise, and take cooked meat, drink pasteurized milk. Next slide, please. To conclude, acute meningoencephalitis is a devastating neurological emergency. Early recognition and prompt treatment helps in minimizing neurological deficit and improves neurological outcome. Neurodiagnostic and treatment modalities present a promising picture in the future. Although the disease has a great burden, still remains high. This is a very protracted disease. Maybe 2 months, 3 months, the patients recover after that. And prevention is always better than treatment. Next slide. Let's pray the Almighty so that we can have the physical meetings. Thank you. Namaskar.
Okay, thank you so much. Professor Das, thank you so much for your nice presentation. Now we will continue with next speaker is Dr. Tu Tian Minh from Singapore. He is assistant professor at UNS Graduate Medical School. And his topic is status epilepticus or seizure management. You have 20 minutes for the presentation, so your time is yours. Please.
Hi, everyone. Thank you for your invite. Let me share my screen. You give me a second. Okay. Thank you for inviting me. Thank you for your kind words. My name is Dr. Tu. I'm actually a neurologist in Singapore, and my interest is in neuro intensive care as well as acute stroke management. So I take care of patients mostly in the stroke unit. I work in both Tan Tock Seng, and now majority of my time is in Changi Hospital. I'd just like to go on the scope of my current talk, which is on seizure management. Even though I'm under the TBI category, I think there is a raised hand. I'll leave the manager of the talk to answer the question. But my talk is on seizure management, in particularly for traumatic brain injury, but I will also cover seizure management in general, as well as for status epilepticus. I'll talk a little bit about what the guideline recommends for patients with traumatic brain injury, the current evidence of what we should do in an acute status epilepticus, and what we can do moving forward, or should I say the unmet clinical needs. But before we start, we need to know how do we define and we classify patients with post-traumatic seizures. We classify them into acute symptomatic seizure in the first 7 days and unprovoked seizure or late post-traumatic seizures if the seizure only occurs after 7 days. This is important because there is prognostic indicators for patients who develop seizures in the early phase versus patients who develop seizures in the late phase. So we also need to know what's the definition, and I think everybody here in this room will know what's the definition of a status epilepticus is where there is motor seizures lasting at least 5 minutes without recurrence of recovery. We used to think of it as 30 minutes, but that was a decade ago. And the reason behind this is that status epilepticus is a condition which you need to treat very fast, very early. And if you don't treat it, the mortality is very, very high. there's another entity where the patient is ongoing having seizures within the brain, but you can't see it clinically except that they are confused because they're not having shaking or abnormal movements. So the recognition is much more difficult, but the treatment is essentially the same. There is a whole bunch of diagnostic criteria, which I will not go into, for how do we diagnose non-convulsive status epilepticus based on EEG findings. But to be safe to say, once patients have motor seizure, EEG is required even if you have aborted the seizure within the next 24 hours to make sure they have not recovered, they're not having non-convulsive status. The key thing about seizures management is you want to prevent them from becoming refractory, which means they continue to have seizures despite you throwing a lot of good medications at them. And the main cause of refractory status epilepticus is actually the delay of the initial treatment. You imagine this as a fire, right? If there is a forest and there is one tree catching fire, you got to put it out really quickly. But because if you let it run and let the fire continues to go, the whole brain will be on fire, and the seizure is very difficult to control despite adequate medications. So let's move a little bit backwards on traumatic brain injury. So the guidelines as of even today recommends phenytoin for 7 days in the early phase of a post-traumatic brain injury, because that actually have some evidence in very old papers based on the NEJM paper that it has reduced the incidence of early post-traumatic seizures. This is for prophylaxis, which means the patient doesn't have a seizure, they have a traumatic brain injury, and you can cover them in a short phase with phenytoin. But of course, this is very, very old evidence, yet it is still considered as a current state in the guidelines. So time has moved on. There are new drugs available. So what about levetiracetam, which is Keppra as we know it, because it is safer, it is less prone to fluctuation, there's less toxicity, there's less side effects, and there's less discontinuation because of the side effects anyway. The answer is there have been no new studies to look at patients in the traumatic brain injury space to see whether the Keppra is as effective as phenytoin. So unfortunately, the recommendations based on the best level of evidence is still based on phenytoin and not on levetiracetam. So you will find that the guidelines mostly still recommend phenytoin. Okay, so let's come down to what do we do in the intensive care or in general ward when we see a patient with a traumatic brain injury or with any seizure. And what you want to do quickly is to treat really, really fast. And this is a very nice graph to show the success of your treatment. If you start the treatment within the first half an hour from the start of the treatment, your success of treating the patient is more than 80%. But it goes downwards if we delay the treatment or we delay an appropriate treatment for the patient. First line treatment is essentially benzodiazepines. So of course, there are many causes of seizure, but let's focus on a traumatic brain injury. But other causes needs to be excluded, especially in a traumatic setting, just to make sure that you are not missing a cause for the seizure. A lot of times in the ICU, because patients are very, very ill, you'll find that they have metabolic disturbances, and you may think that maybe the metabolic disturbance is the cause of the patient's seizure. The most important thing is that there are cutoffs, there are recognized cutoffs where we would say, yes, maybe the low sodium is the cause of the seizure, but in the absence of perhaps maybe the sodium is 125, that is not good enough to indeed cause the seizure. So we should not attribute that mild loss, low sodium or calcium to be the cause of the seizure, but treat other causes or try to find other causes of seizures. So the first part is maintenance and prevention of further injury because of the seizure. Continued seizure will actually aggravate that primary brain injury, and in fact, it will cause systemic injury, especially if the seizure is not controlled and you get rhabdomyolysis and as well as acute renal impairment. In every hospital, you should have a fixed set of protocol because this is an emergency and it can happen at night. The person on call or your MO should be able to follow the protocol and treat the patient. So a pre-planned protocol should be in place everywhere easy access for anybody who is working in the hospital at night. And this is the protocol in my hospital, and we follow this whenever somebody has seizures. We'll give lorazepam or diazepam, and depending on whether you can get IV access, actually intramuscular midazolam is also recommended, because we know from the study, which I'll present later, is that there is actually minimal difference between IV lorazepam and IM midazolam. So having no venous access is not a reason not to give benzodiazepine. So immediately after you have given the benzos, the next thing is to follow up the patient with anti-epileptic medications. The patients, just by giving benzodiazepine, because it's short-acting and it is only a temporizing thing, you're going to maintain the patient to prevent them from having a seizure recurrence or improve the control of the seizure. So the three drugs that we strongly recommend nowadays are phenytoin, valproate, and levetiracetam, because the evidence of comparing these three drugs are just as efficacious. In fact, I have observed over the years, most of us are moving towards levetiracetam because of easy application. You don't have to monitor the BP and the ECG, which is what we used to do when I was a very junior doctor. We would sit there with the ECG and BP machine. So levetiracetam is now recommended. It depends on what is available in your hospitals. This is the recommended. One of these drugs will be recommended as long as it's available. We try not to give more sedating drugs, but if needed, and if the seizure continues, you will find that we use phenobarbital, propofol, and these are second-line medications as listed over here. Again, I strongly recommend for every one of you who are working in various hospitals to develop your own protocol based on evidence so that it's readily available at night when your patients require them. And as I mentioned, lorazepam and IM midazolam, all of them are very effective. You can choose any one of them. And I emphasize again, you need a second agent after even the termination with the benzodiazepine. This is the paper to compare between intravenous lorazepam and IM midazolam. This is in a pre-hospital setting where patients with seizures coming to the hospital for whatever cause, and the paramedics allowed to give them IM midazolam, and you find that the seizure termination with IM midazolam is much better than IV lorazepam, perhaps due to a delay of setting the IVs. And time to treatment is actually much faster. So overall, they are comparable in efficacy. So when we come down to, okay, I've given the benzodiazepine, what should we do next? As I mentioned, phenytoin, valproate, and levetiracetam are equally effective. And this is coming from the paper that was just published 3 years ago now. It is a randomized control trial of these three anti-epileptics, which I've mentioned before. And you'll find that the outcome which they want to look at is termination of the motor seizure within 60 minutes. And it also includes pediatric patients in this trial. So we know that it is generalizable to the children age group. And you'll find that these are the recommended doses based on the paper. The dose for the levetiracetam is very high. It's very, very high, 60 milligram per kg. This is a dose that we may not be comfortable with in our hospitals. We usually give 20 milligram per kg in the for levetiracetam, but the trial, to be successful, is given at 60 milligram per kg. So that is something to be remembered, because an average 50 kg or 60 kg person will require 3 gram or 3.6 gram of levetiracetam as for a status epilepticus abortion dose. I just move on to the slide. This is just the main conclusion. There is no difference between the efficacy of these three drugs. So you should give these three drugs after your benzodiazepine, and any of this will show similar efficacy regardless of your etiology. Because in this case where the study was done, it was a varied etiology, and some of them had traumatic brain injury, even though the subset was not very high, but the drugs were equally effective. And main thing is about the safety. You'll find that the safety for levetiracetam is very, very good. And it is in fact something that has moved patients towards giving levetiracetam nowadays. A further study of the ESETT trial, which includes more patients of the same study and includes more children. And the conclusion is rather similar. Okay, so you'll find that in children, you will also be able to use levetiracetam, valproate, or phenytoin effectively. And if you look at adults, you'll find that maybe valproate has a slight edge of efficacy in adult population. So this is also a list of doses that you can use with the other drugs. For example, ketamine, propofol, pentobarbital. These drugs are used as a second line when your first line is not as efficacious or you have not successfully stopped the seizures. And maintaining the AED for at least 24 to 48 hours is like resetting your computer. You have to reset it, you have to wait, chill, let the brain recover before you wean off the anti-epileptics. What you don't want is you successfully stop the seizure and you aggressively take off the anti-epileptic medications. And routine EEG, which is what we recommend, is based on the resources available in your hospital to look for non-convulsive is recommended. So there is another entity, and we have seen this very, very frequently, is what we call a super refractory status epilepticus. What does that mean is that patients are already given benzos, given all your 3 AEDs, and given the second line AED, such as phenobarbital or your propofol, and they're still having seizures. So usually in this stage, there's very small, weak evidence on ketogenic diet, which can be tried to help to improve the control of the seizures. Okay, next slide. So the main thing is, why do treatments fail? It's usually because we as clinicians don't recognize that this is a seizure. We don't recognize that we need to treat it quickly. We don't give the correct dose, we wait, we delay, and that results in the fire burning out the forest. So early treatment is very important. I cannot emphasize this. And the person who treats the patient right at the start, so the E&E physician or the on-call medical officer, makes all the difference in getting the patient better. So moving forward, there have been reviews and updates of the treatment of seizures in general. And the conclusion is what I mentioned. Early benzos within 30 minutes of onset is critical. Combination of levetiracetam and phenytoin appears to be more efficacious if you want to use 2 drugs. Yet, if you use the first drug that you want to use, sodium valproate, has shown to terminate status epilepticus fastest and more efficacious in the adult population. So I summarize is that when we see a patient with seizures, even in a post-traumatic setting, is to hit hard, hit fast. Once you stop it, you hold, and then you let it go gently. So thank you very much. I will be happy to take questions, if any.
Okay, thank you, Dr. Tutianing, for your nice presentation. So we will next to the last our speaker is Professor Masahiko Kawaguchi from Japan. He is a professor and chair of the Department of Anesthesiology, Nara Medical University. He is also the president-elect of ASNEC and the vice president of Japanese Society of Cardiovascular Anesthesiologists. And also he is a secretary general, Japanese Society of Neuroscience in Anesthesiology and Critical Care. So you have 20 minutes, Professor Kawaguchi. It's really nice to meet you again after Nara session.
Hi, nice to see you again. Thank you for the introduction, Dr. Bisbee. It was nice. I was really appreciate to have this opportunity to give a talk today. I really congratulate the organizing committee this well-organized meeting. Thank you very much. So I will share my slides.
Okay, please, Professor.
Just a moment.
Okay.
Can you see the slide? Okay.
Not yet.
Not yet.
Okay. Now already see.
Can you see this one? Okay.
Yes.
The topics of my talk today is about paroxysmal sympathetic hyperreactivity. There is no conflict of interest alleged in this presentation. Nara is the first place of capital of Japan and biggest Buddha and Nara Park, where a lot of deers are walking around. It's so famous and located in the near Kyoto and Osaka. This is a picture of the sixth Congress of Asian Society for New Anesthesia and Critical Care, which was conducted in 2019. That was so exciting event because more than 400 people from Asian country can get together. That was exciting, and it was so lucky because just before the COVID-19 infection pandemic started. This is a great interesting pictures. At the beginning, I would like to share the case of PSH, which was published in the literature. Here's the case one, a 30-year-old male with no past medical history. He was found unresponsive at home with homing secretions around his mouth. Paramedics found his apneic and pulses. A cardiopulmonary resuscitation, CPR, was initiated, and he had recovered spontaneous circulation after prolonged CPR. He was admitted to ICU and started on therapeutic hypothermia. Antibiotics and vasopressor was initiated for septic shock, along with mechanical ventilation and intubation for respiratory failure. Here is the laboratory data of this case, which indicate an increase of leukocyte count, creatinine, AST/ALT, and lactic acid. Here is EEG of this patient, but indicated encephalopathy without seizure activity. Here is MRI imaging. So it showed hyperintensity in bilateral basal ganglia, like this here. On day 3, he had a repeated episode of twitching, decerebrating posturing, and eye rollings. Repeat EEG shows similar results to prior EEG. He continued to have repeated episodes of decerebrating posture, rhythmic jaw movement, sweating, fever, and tachycardia. He ultimately required tracheostomy and gastrostomy tube replacement. He had negative blood culture, sputum culture, and urine lesion out, and the thyroid function test did not show hyperthyroidism. Hepatitis B and hepatitis C, interferon gamma were negative. So no evidence of other infections were noted. He was started on acetaminophen for fever and baclofen for rigidity. At this time point, he was diagnosed with paroxysmal sympathetic hyperreactivity, PSH. He was initially started on the regimen of bromocriptine and propranolol, but his response was poor. Clonidine and diazepam was added to regimen, which eventually helped with his symptoms. He was then discharged after prolonged hospital course, which can show a little delayed diagnosis of PSH after the exclusion of other diagnoses. Here is the second case. A case of 27-year-old male who was aphasic, tetraplegic following a traumatic brain injury, TBI, with severe right hemisphere lesions sustained in the road traffic collision. 5 months after the accident, the patient was readmitted to the hospital because of nosocomial pneumonia and was started 10-day course of antibiotic meropenem. No pathogens were isolated from blood, sputum, and the patient improved clinically to be safe, stable, and warm air, with no respiratory symptoms and negative inflammatory markers. Despite the apparently treated infection, the patient was still febrile, with his temperature rising to 39.5 degrees once or twice a day, with very little evidence and very little response to antipyretic drugs. During this episode, the patient became tachycardia, hypotensive, tachypnea, and sweated profusely. The patient's mother reported that these episodes were also frequent at home, and that because of that, the patient had been refused care in the specialized rehabilitation hospital, and he was thought to be infectious. A complete septic screening was performed, including blood, sputum, urine, liquor samples, but no bacteria, yeast, fungus was found, and no other inflammatory markers were positive. Both renal and liver functions normal. Then finally, in the delayed fashion, PSH was considered a cause of the patient's febrile episode. This is similarly, the diagnosis was delayed because after the exclusion of diagnosis. Here is a paroxysmal sympathetic hyperreactivity assessment measures of this case. First, clinical feature scale, CSF. This score is 13, which indicates severe severity. And the diagnostic likelihood to DLT is subtotal number is 9, and the combined total is 22, which indicate PSH diagnostic likelihood is more than 70, which indicate probable PSH patient. So, as shown in the cases, there's a difficulty to diagnose PSH because PSH is a diagnosis of exclusion with paroxysmal and persisting despite treatment of alternative diagnosis, including pain, sepsis, opioid, or sedative withdrawal, neuroleptic malignant syndrome, pulmonary embolism, and delirium. So diagnosis of PSH may be delayed. However, since PSH is associated with increased healthcare costs, longer duration of a hospital admission, and worse neurological outcomes, recognition and management of PSH is very important. The topic of my talk today is here, definition of diagnosis of criteria, epidemiology, pathophysiology, and finally treatment. First, definition and diagnosis criteria of PSH. This is the terminology of PSH. First, this was described by Walter Penfield in 1954 as mesencephalic seizure. Then various different names, sympathetic storming, autonomic dysfunction syndrome, many terminology were used, but finally 2014, expert consensus indicated that the terminology decided to use PSH. So this consensus identified that PSH is a syndrome recognized in the subgroup of survivors of severe acquired brain injury of simultaneous paroxysmal transient increases in sympathetic activities, including elevated heart rate, blood pressure, respiratory rate and temperature, sweating, and motor activity. This is a core clinical features of PSH, which include tachycardia, hypertension, tachypnea, fever, sweating, and increased muscle tone with possible dystonia posturing. This is an exclusion of PSH. This is an important things for the diagnosis, include seizure, sepsis, hypoxia, hypoglycemia, pain, spinal cord injury, previous neurological illness, medications affecting autonomic nervous systems. So this is identification of PSH. PSH assessment scale, PSH AM scale used, which consists of two separate constructs. One is the clinical feature scale, CFS, to identify the intensity of cardinal features. The other is a diagnosis likelihood to DLT, to evaluate the likelihood of the presence of PSH. CFS, clinical feature scale, consisted the categories including heart rate, respiratory rate, systolic pressure, temperature, sweating, posture during episode, and calculates total number. This is diagnosis likelihood to DLT, which consists of 11 items. Clinical feature, episode of paroxysmal in nature, sympathetic overreactivity, and feature persists more than 3 consecutive days, persists 2 weeks post-injury, and persists despite treatment of alternative differential diagnosis, etc. And we can check these items. And finally, CFS score subtotal to identify the severity of clinical features. If more than or equal 13 points, that is considered as severe. DLT score subtotal is calculated, and finally PSH-M score, which is total combined CFS score and DLT score to diagnose likelihood of PSH. If the total score is more than or equal 17 points, PSH likelihood is probable. Here is PSH AM score as shown before in case 2. As CSF score is 13, so severity of clinical feature is severe, and the DLT score is 9, and the combined total is 22, so that is more than 17. So PSH diagnostic to likelihood is probable. This patient can be diagnosed as a PSH. Next, epidemiology about PSH. The incidence of PSH was traditionally described in severe acquired brain injury, ABI patients, including traumatic brain injury, anoxic brain injury, stroke, tumors, infections, and specified causes. Many causes are included. Approximately 8 to 33% of patients with ABI develop PSH. Relatively high percentage of the patients develop of PSH. There is an incidence of PSH among patients with ABI who develop PSH. 80% of the patients moderate to severe traumatic brain injury, 10% of the patient anoxic brain injury, 5% stroke, 5% include hydrocephalus, tumors, infection, or unknown causes. Mostly traumatic brain injury patient is prevalent. Here is the incidence and the duration of PSH. In severe TBI, occurrence of PSH range 15 to 33%. After moderate to severe TBI, the duration of PSH is on average 18 to 162 days. It's quite a long time after the injury, and in most cases resolved within 1 year. So it can develop even after 1 year. So in case 2, this is a little delayed portion. Here is independent risk factors for PSH in TBI patient. The result indicated that male contusion, diffuse anoxic injury, complete cysternal effacement, intravenous hemorrhage, subarachnoid hemorrhage, ICU admission systolic pressure was a significant determinant to risk factors for PSH in TBI patient. Here is the pathophysiology of PSH. This slide shows pathophysiology as a disconnection theory. Several mechanisms are proposed. Connection of cortical inhibitory center insulin or cingulate cortex to sympathetic control center. Hypothalamic, the encephalic, and the brainstem centers is disconnected in TBI brain with PSH in the right side. Disconnection theory. The other theories which is proposed in the next version is excitatory inhibitory ratio model. In normal, the balance between inhibitory and excitatory interneural activity is maintained in the left side, right? And the TBI with PSH, the disconnection of descending inhibitory produce excitation of feedback loop, where non-noxious stimuli is potentially preserved as non-noxious stimuli. A similar schema is described in Lancet Neurology. Right side PSH, even non-noxious sensory input, which induce increased sympathetic output, increased motor output in the patient with PSH. Finally, we talk about treatment of PSH. Pharmacological treatment includes opioid, intravenous anesthetics, beta blockers, alpha-2 agonists, benzodiazepine, neuromodulators, periphery acting muscle relaxant. At first, opioids, majority of PSH paroxysmal occur as allogenic responses to external stimuli such as pain, urinary detention, and movement. This is an important symptoms. So opioid, especially morphine, are probably the most frequently used and often first-line agent to suppress the allogenic response in PSH patients. Other agent is alpha-2 adrenergic agents. Alpha-2 adrenergic agent act through central as well as peripheral suppression of adrenergic outflow. In PSH, clonidine reduce heart rate, blood pressure, circulating catecholamine, and dexmedetomidine has also been reported to be effective in managing PSH, and especially in ICU patients. Here is a report regarding the effectiveness of dexmedetomidine on the PSH patient. This slide in this report indicated that in patients having dexmedetomidine, PSH-AM score is significantly less compared with the patient without dexmedetomidine, which indicated that dexmedetomidine has a preventive effect on PSH in severe TBI patients who have undergone surgery. Next is the beta blocker. Beta blocker is one of the first choice medicine, which reduce the frequency and severity of PSH by diminishing the role of circulating catecholamine and lower the resting metabolic rate. And non-selective beta blockers, propellant role is considered to better compared with selective beta one because lipophilic properties which are low to cross blood-brain barriers. Here is a report which indicates that effect of beta blocker on in hospital mortality in TBI patients, which indicated that beta blocker, the patient had a beta blocker has less in hospital mortality in TBI patients. Odds ratio is 0.39. Here's the effects of beta blocker on favorable outcome at the discharge on the long-term outcome in TBI patients. This report indicated that patients with having a beta blocker has more favorable outcome at discharge and longer term, 6 months functional outcome. Odds ratio is 1.75. which may indirectly indicate that beta blocker may be useful in TBI and may be effective on the PSH development. The next one is other modulators, which includes bromocriptine, baclofen, gabapentin, and dantrolene. Such kind of modulator can be also used as a pharmacological agent. Finally, non-pharmacological treatment are shown, which include avoid external stimulus. This is an important thing because that such kind of stimuli can trigger the paroxysmal events, and also intravenous rehydration, correct electrolyte imbalance, environment control, energy supplies, and hyperbaric oxygen therapies have been reported in some literatures. Here is a basic pathophysiology manifestation of PSH summary. A diffuse multifocal acute brain injury, which indicate this inhibition of sympathetic response resulting in paroxysmal sympathetic hyperactivity. And when external internal triggers developed, which induce recurrent episode of sympathetic activity, including tachycardia, hypotension, tachypnea, fever, diaphoresis, dystonia. And this is a principle, summary of principle of PSH treatment. At first, it is important to reduce external stimulation because allogeneic mechanism is also important things. And as a drug therapy and abortive therapy, IV morphine, IV beta blocker, especially propranolol and dexmedetomidine may be efficient. And as preventive nature, gabapentin, oral beta blocker, clonazepam may be considered as a treatment. Here the final slide as an algorithm pathway for managing PSH. As I mentioned before, exclusion of other diagnoses important at first, including infection, sepsis, and separophagy withdrawal syndrome. Then calculate the PSH score and total score, depending on total score, which probable or possible and unlikely we can determine. Then, if the symptom tachycardia, tachypnea with there, a non-pharmacological therapy or pharmacological therapy started, and so prompt recognition and treatment would be important because PSH may be delayed for diagnosis, and such we should keep in mind this kind of syndrome in the clinical situation. And thank you very much for your attention. Thank you.
Thank you so much, Dr. Kawaguchi. So all the speaker is already presentation. Now we will go to the next step is discussion session. Maybe any question for the participant? You can show me. I already see on the chat room for Dr. Tu, you already have some answered so many questions in there. Maybe have the other question for another speaker, for other speakers. Okay, this is for Professor Hari Hardas. Are you still with us, Professor?
Yes.
Okay, you have a question. In a few cases of the meningitis, a pair of hydrocephalus, some case the solution is after the physician. So my question is the patient with the GCS below 8, is there any consideration based on your experience to decrease the ICP? Does the patient with the GS below 8 has done physician surgery need to maintain the ETT, or it can be changes with the NPA?
Now, if to be very frank with you, I couldn't follow the question, but still I think what I can make out if the Glasgow Coma scale is less than 8, and if there is BP shunt, okay?
Yes. Is that still consideration based to your experience? Is it it can be useful to decrease the ICP?
No, if the BP shunt is there, if the BP shunt is functioning, then there is no need. But still, suppose if the ICP is high, ICP may be high because of other reasons, like the contusion may be increasing or the hematoma may be increasing. That may give rise to increase in ICP. Or the shunt may be blocked. So the shunt may be blocked can be known by aspirating and examining the shunt. And suppose if there is no mass lesion, still ICP is increased, which you see through CT scan, then you can do a shunt tab and remove the CSF 5 ml aliquots or slowly, then you can see whether your patient has improved or not. That can be done.
Okay, thank you, Professor. I think I have one question for you. In
Yes.
one of your slide and the long term of complication, you already tell or writing over there is memory difficulty, isn't it?
Yeah.
Yeah. Is there any treatment for the patient when the patient is got the memory difficulty? Any suggestion what should we do to the patient?
Now, the best thing is memory difficulty occurs because of the destruction of the neuronal cells. So once the neuronal cells are destroyed, it is very difficult to recover, but the recovery occurs over a period of time, slowly. So it is the rehabilitation. You try to bring his memory back by talking to him, by discussing his past good events, so that he will recollect. But other drugs, encefabol and other things, the neurologist, they prescribe, but I don't think those are of any help.
Okay, so it's not then have a place for the calculating game or maybe something like a brain game. Is that possible to give to the
Yes,
patient?
that's true. That is the best way to rehabilitate these patients.
Okay, thank you, Professor. Maybe have another question for another speakers. Okay, I have a question for Dr. Tu. Or maybe here. Oh, okay. Still not yet. I have a question for Dr. Tu. If a patient, we already treatment the patient with the phenytoin as anti-epileptic about 7 until 50 days, but the patient is still got in seizure, but not really frequently. So what should we do? What should we do?
I think if your question is if a patient has prolonged seizure for many, many days, the main thing that we want to do is, number one, we want to ask ourselves, have we tried to optimize all the necessary medications? And if we have tried 4th line, 5th line, 6th line medication and the patient is still having seizure, then next question is we can try a lot of off-label treatments. There is this entity called new onset refractory status epilepticus, where it's a third of them are autoimmune in nature. So trying some off-label immunosuppressive agents such as IVIG or methylprednisolone have some evidence. But usually, I have to be honest, the mainstay of care will be actually to have a sit-down discussion with the family about the futility of care, because I do have patients who we try 5, 6, 7, 8 drugs, and the drugs are already affecting the liver, depressing the respiratory drive. There can be a chance where the patient may have cortical damage from the brain from overactive seizures. So having that open discussion with the family that about futility of care may need to be considered.
Okay, thank you, Dr. Tu. Now we had a question for Professor Kawaguchi.
Yes.
Wait for a moment.
Oh, that disappeared, but
Okay.
yes.
Okay, the first question. Do you advise for regular preventive measure for PSH with beta blocker, clonidine, GABA in every severe traumatic brain injury patient? And if yes, what does that you recommended for either clonidine or beta blocker for your choice?
Yeah, thank you very much for an interesting question. I think I don't know. It's every patient we should administer, but if any signs, any possible patient, we may consider such as a preventive drug. I'm not actually. I don't know the exact doses, but the literature indicated that for propranolol. For prevention, 20 to 60 milligram, 4 to 6 hourly is for the preventive nature, and also clonidine for prevention, 100 microgram, 8 to 12 hourly, and also gabapentin for the prevention, 100 milligram, 8 hours can be used. So I'm not actually, but this literature indicated. So we may use can be challenging in the cases with some signs, possible PSH patient.
Okay, thank you. And the second question is how the hyperbaric oxygen therapy can be used as a treatment for PSH.
Okay, thank you very much. I'm not having any experience, so I got the information from the literature. So exact measures to how hyperbaric oxygen therapy how used. Sorry, I cannot answer in this time. Probably we should check. But some literature, the efficacy of the hyperbaric oxygen therapy in PSH patient was reported. Thank you very much. So. Sorry for the no answers.
It's okay. You still have one question. Maybe one more is from me. But this is the next question is, do you advocate the recommended usage of Precedex as sedation is all severe traumatic brain injury patient in order to prevent incidents of PSH?
Yeah, that is a good question. Precedex is considered is useful drug to prevent, and also in the ICU cases, Precedex has been used in most of the patients. So Precedex is one of the first choice as a sedative, and also can be used to prevent PSH in TBI patients. Thank you very much.
This is for my question for you, Professor Kawaguchi. Your slide is talking about the bromocriptine, isn't it? A treatment for bromocriptine.
Bromocriptine, okay.
Yes, bromocriptine. Is the patient is a woman with postpartum? Do you still given for bromocriptine? And the second is, what the function of bromocriptine in PSH? Thank you.
Okay, many drugs has been used in the treatment, and also PSH is a syndrome. So many mechanisms, many regions, so a variety of mechanisms which can depend on the patient. So it is difficult how affected. So I cannot identify the exact mechanism efficacy, but some levels indicated in some patients it was effective, in some levels other drugs will effective. So sorry, I've got exact data, exact experience in the broad community. Sorry.
Okay, thank you. Thank you so much. Is there any question? I think that's all question is already answered. So better we close this session. Thank you very much for all speakers and for all participants. Have a nice day. Thank you so much.
Thank you.
I think the committee will continue the event. Thank you.
Thank you, speakers and moderator, for the third session of plenary lecture. To all the panelists, we welcome you to open the Zoom camera. We are gonna take a photo shoot together. For Professor Dash from India, please.
Dr. Pimwang Sokplong from Thailand, please open the camera.
Thank you, all the speakers and moderators. Thank you to all participants who attended this event.
Now that we are at the end of today's event, we will continue this event tomorrow.
I am Ada Mayanti.
My name is Vesta Antares. Farewell to resign. Thank you all and see you tomorrow.
Yoga Banjarmasin Nandingarani kota seribu sungai. Yoga Banjarmasin kota nang tapandang wanang paling bungas. Yoga Banjarmasin Nandingarani kota seribu sungai. Yoga Banjarmasin kota nang tapandang wanang paling bungas. Yoga Banjarmasin Nandingarani kota seribu sungai. Yoga Banjarmasin kota nang tapandang wanang paling bungas.
To all for all the participants who attend today's event, we will remind you again. Tomorrow we still have a lot of interesting lectures from across countries speakers. All the participants for today's attend, and we will see you tomorrow. Don't forget for attending tomorrow's event. Thank you.
pesanku ini, alahai batakun sudah sampai saku lilingan. Umai padahkan lawan dinya, alahai memilih antah jangan di dalam bani. Purun-purunnya ahai malincai ulas hati, manjatu pamandiran piragah wandi, piragah tapang rasa, manjatu kambang layu, ibarat kumpai laru, salajur hanyut, salajur hanyut. Lawan dinya, alahai memilih antah jangan di dalam bani. Purun-purunnya ahai malincai ulas hati, manjatu pamandiran piragah wandi, piragah tapang rasa, manjatu kambang layu, ibarat kumpai laru, salajur hanyut, salajur hanyut, salajur hanyut, salajur hanyut. Sampai akan yuka bulik pangsa tuman, bulik pangsa tuman, lawasnya menghadang pian meninggalkan kampung halaman tapa purunan. Yuka bulik pangdamini, bulik pangdamini, ulun tak sakit hati pianang ulun tangisi, kada sakira diri ulun barista. Yang datang ulun sambut lawan mayang, ulun hamburi baras, si baras kuning bersemangat di muhara lawan. Pian datang ulun sambut lawan mayang, ulun hamburi baras, si baras kuning bersemangat di muhara lawan.
Adi sayang kakak pasti ulah, hadang din hadang kena kakak akan datang. Hati kakak ini sudah bujur dan damai, lawan pian yang ada di kampung halaman. Kakak pasti pulang bawa duit kasan, jujur pian. Kakak ini bujuran, menjadi modal kadang